Not quite ready. Now we can hear me. Okay. Hi, guys. I'm Nicole. I'm going to do the housekeeping slides really quick. I'm taking one for the team for Matthias so he doesn't have to do all this stuff. So welcome. Oh. I'm making this guy work on the fly. Sorry, I started speaking too soon. Okay. How do I forward? Okay. So really quick, this is important. If you're not on Wi-Fi yet, here's the Wi-Fi passcode. I believe that's somebody's phone number. I haven't tried it yet, but it does look like a phone number to me. Is it? Okay. Are we good? All right. So the sign-in sheet, this is helpful for numerous reasons. Make sure you sign in. I will send you post-program follow-up, post-test, eval, claim credit. We added ABIM, MOC credits to this session and next week's session, and all of that information will be sent to the information you give us on the sign-in sheet. So even though you registered, that's to let us know that you intend to come. This tells us you came. And so if you are online listening to this, on session 2 tab on the website, there is session information on the right-hand side. You will see pre-test, you will see sign-in sheet. I will also use the Zoom login information as sign-in. So I'm just letting you know where all of this information is. It's a little redundant, but we want to make sure we capture you so that we can send you the information that you need. The pre-test. This is if you intend to claim credit of any kind. Please do complete the pre-test. Again, it's also available on the Session 2 tab under Session Materials. Okay. Everyone's here, so you've already parked or figured out something. But just so you know, we are validating parking at 1331 West Fulton. So if you did go all the way down there and walk all the way up here, thank you for tolerating the distance, and we will validate your parking ticket so you don't have to pay for it out of pocket. Silent your phones, please. And Q&A, we will have mics that we're running around. Do try to make sure that you have a mic when you're speaking. It will help our online people hear you and everybody else in the room hear you. This is our faculty for today. Matthias will be coming up to introduce everybody. So also in your guidebooks, we have a list of all the faculty as well as mini bios if you're curious to read a little bit more about them. Our agenda for today, and then let's get started. So Matthias.
Hi, welcome everybody. Welcome to our second session of our winter CME series. Today we have a very interesting program about women's cancers and GU malignancies. So let me introduce first our first speaker, Dr. Tom Westbrook. He's a hematologist oncologist at Rush University. He's a GU specialist focusing on all genitourinary malignancies, and he will be talking about updates in bladder and kidney cancer from ASCO GU and most recent updates. So welcome, give a huge welcome. Thank you.
Thank you. All right, I'm mic'd up. People hear me? Okay. We're getting going for the online folks. I will be using the laser pointer to refer to things in the room. I apologize to those that are online. They won't be able to see that, but I'll try and narrate as I go. So As Matthias said, I'm be giving updates in bladder and kidney cancer. Disclosure, I was on a J&J advisory board, not relevant to this talk. As far as learning objectives, I'm going to discuss current neoadjuvant strategies in the setting of the Niagara trial, review changes in the selection of later lines of therapy based on Tropics 04, discuss renal cell carcinoma epidemiology and subtypes, identify the treatment options in metastatic non-clear cell renal cell carcinoma based on the SUNY forecast results, talk about management of second-line kidney cancer, specific clear cell renal cell carcinoma, and then talk about the updated Checkmate 214 results implications. So I guess I should say this is not meant to be a comprehensive overview of any of these topics as far as the management of kidney cancer or the management of bladder cancer. It's far too large of a talk for today. So I will do a little bit of background, but it's really going to be focused on practice-changing updates from the last year, so 2024. So going into bladder cancer epidemiology, before we get going, the incidence around 83,000 with close to 17,000 deaths per year. It's a diagnosis of later life in general. Median age is 70 at age of onset. Earlier onset in smokers, and that is the biggest risk factor. It is male predominant disease, a 4-to-1 male to female ratio. Other risk factors include occupational carcinogen exposure. And this is thought to lead to a field cancerization effect in that often people will have recurrent bladder cancers that are different from one another. However, when you have a multifocal urothelial carcinoma in the bladder, it is actually often monoclonal, so arising from a single cell. Other risk factors include chronic cystitis, cyclophosphamide, certain bladder irritants. And then genetics, family members do seem to have increased risk if they're a first-degree relative and generally diagnosed earlier in life. When we're talking about bladder cancer in the United States and Western countries at least, we're talking mostly about urothelial carcinoma. You might also be familiar with the transitional cell carcinoma, same thing. That's be 90% of cases. And that's really what I'm going to be talking about. So when we talk about the different phases of the disease, starting with non-muscle invasive, that's about 50% of cases. Muscle invasive disease is into the muscle layer of the bladder. That is a more serious diagnosis in that that has the potential then to spread. That's about a third of cases. And then the rest of cases are either regionally advanced or 5% are metastatic at time of diagnosis. So when we're talking about muscle invasive bladder cancer, which that's where I'm going with this, as far as definitive therapies, the choice is primarily between cystectomy, so removal of the bladder, plus minus neoadjuvant and or adjuvant therapy, or a bladder-sparing approach with a maximal transurethral resection plus chemotherapy and radiation therapy concurrently. Those are kind of tried and true. Most patients should receive neoadjuvant therapy prior to cystectomy. And prior to the Niagara trial, which I'm going to talk about next, really the choices are between dose-dense MVAC, which is a 4-drug regimen, versus gemcitabine and cisplatin. Depending on the pathology from cystectomy, adjuvant nivolumab may be warranted, and that would be specifically in some cases T2 or higher or node-positive disease. So enter the Niagara study. This is a slide overviewing the study design. The study population was in patients with muscle-invasive bladder cancer, so T2 or higher. They actually could have N1 disease as well, although very few patients actually did. And they did allow minor variants, but it had to be urothelial predominant. Otherwise, I think pretty standard inclusion. And the intervention was really adding durvalumab, so anti-PD-1 therapy to standard therapy, which is gemcitabine and cisplatin. And the comparator arm was gemcitabine and cisplatin. So each arm had over 500 patients, so over 1,000 total. And the primary endpoints were event-free survival and pathologic complete response rate. Um, so as far as baseline characteristics, you can see in this table, most patients were white, most patients were male, and very few patients had node positive disease. Most patients actually did have positive PD-L1 staining as well. So looking at pathologic complete response, which is one of the primary endpoints, this is the reanalysis. So they added a few additional cases that they didn't initially have when they did the initial analysis of pathologic complete response rate. And you see when they included these extra cases, they do see a significant difference in favor of the durvalumab arm, about 10% higher on the path CR rate, which is a highly significant finding, had a very high threshold, or very, I guess, low p-value for their saying that that was significant. So on the reanalysis, was significant. A caveat to this is that these path CR rates are much lower than what you would expect from previous neoadjuvant studies. So that's a little puzzling as far as why we're seeing 10% improvement, but both of them really below what we might expect from just previous studies. So looking at efficacy by event-free survival, you can see both at 12 months and 24 months, significantly fewer events in the arm that received durvalumab. I should have mentioned in the previous slide, the durvalumab received this neoadjuvantly and also 8 cycles adjuvantly. So this was baked in. Both neoadjuvant and adjuvant therapy with durvalumab was part of this study. And it was not based on the cystectomy pathology. As far as overall survival, this is still relatively immature, but you can see at 12 months a small improvement. At 24 months, a little bit larger of an improvement in the durvalumab arm. And in terms of safety, I think there's really nothing new here in terms of anti-PD-L1 or anti-PD-L1 therapy. Added a modest amount of AEs and perhaps 10 to 20% might discontinue due to durvalumab, although sometimes difficult to attribute that. So I think the takeaways from Niagara is that perioperative durvalumab did lead to improved pathologic CR rates, improved EFS, and preliminarily seems like overall survival as well. Patients did receive durvalumab regardless of pathology, and no patient received, that's not actually true, 4 patients received adjuvant nivolumab in the control arm because it wasn't standard of care at that time. So this leads to our current practice, applying this to our current practice environment is a little bit challenging that setting in terms of how many of the patients, if they had been eligible for nivolumab and gotten it, would they have had the similar outcomes? That's something we don't know. So we can say that the path CR rate, though, that to me does seem real, since that is pure neoadjuvant, apples to apples comparison, a 10% approval in that, even if both of them are relatively lower than other trials. We really shouldn't be doing cross-trial comparisons on this because they are different patient populations. So we're currently awaiting regulatory approval. This is before the FDA, last I saw. And I think everyone expects that this will be approved, and this will become basically standard of care. The question is going to be, do we do adjuvant durvalumab in folks who have a pathologic CR? I'm not sure that I will. And so we're now deviating from what the trial did, which is kind of an interesting space to be in. Other studies in this space, like the Keynote 866 study, which is adding pembrolizumab to gemcitabine cisplatin, or EV304, which is enfortumab vedotin and pembrolizumab, are still in process and will read out over the next year to a couple years. And I would say for now, durvalumab probably is going to become standard of care in addition to chemotherapy. So moving on to metastatic bladder cancer, this is not an update for this year, but enfortumab vedotin and pembrolizumab is the standard first-line therapy for more than a year now. Really December of 2023 is when it was approved by the FDA and presented at ESMO 2023. This has led to downstream effects of what are second, third line therapies now in an EV-Pembro first line world. So most use chemotherapy as a second line. So gemcitabine, carboplatin, gemcitabine, cisplatin is a pretty, I think, common second line. There's no clear winner for what's the best third line agent. For folks that have an FGFR3 mutation, erdafitinib is a good option. Difficult to tolerate, but a good option. For HER2 positive, IHC3 plus positive patients, in HER2, so trastuzumab deruxtecan has been approved. That actually was in the last year. That's been approved pan-tumor based on the pan-tumor Destiny 02 trial. So that is relatively new, but it's only 10% of patients roughly with metastatic urothelial carcinoma that will have a 3 plus. So sacituzumab govitecan was an option until very recently versus single agent chemotherapy. So going into sacituzumab govitecan, the TROP2-directed antibody drug conjugate, it was initially approved, accelerated approval in metastatic triple-negative breast cancer in 2020, and then received accelerated approval in urothelial carcinoma in 2021 based on TROPHY, which is a single-arm phase 2 study. It was withdrawn in October of this past year after a negative study in TROPIC-04. So I'm just going to talk about that very, very briefly, but basically no longer an option, at least on label, to use in urothelial carcinoma. So TROPIC-04 was a study in metastatic urothelial carcinoma on patients that had progressed on platinum and PD-L1 therapy. And basically sacituzumab govitecan, the drug antibody conjugate, versus 3 different single agent chemotherapy choices. The bulk of this study was done in Europe in terms of where the patients were accrued, but it was a global study. Basically, there were some early safety signals that the sacituzumab does have an issue with severe neutropenia, and they chose not to mandate prophylactic G-CSF, mostly for logistical reasons of difficulty of doing that in the different countries. So basically, what we see with the overall survival curves is that there's actually an excess number of deaths very early, probably from more grade 5 or death-causing adverse events. And then they actually separate a little bit, but unfortunately, not enough to be statistically significant in terms of sacituzumab being a winner in terms of overall survival. So this was withdrawn voluntarily by the company based on this. The safety summary, we can really just see that really we have 25 deaths related to treatment versus 7 in the single agent arm. So it trended towards improved overall survival. Some of the other endpoints that we look at were also a little bit better in terms of trending, but more treatment-related deaths. Some people think that, really the prophylactic G-CSF could have saved this trial and kept the approval. It wasn't done. So this has led to a lot of, issues for the trials that are using this as a comparator in ongoing bladder studies. They're kind of in flux. Whether we're going to be able to get it approved off-label, since it's still approved in triple-negative breast cancer, kind of remains to be seen. I have been able to keep patients on it, but I have not tried to initiate anyone yet. I'm sure that I will at some point because I think there is a signal for efficacy and you run out of agents kind of to use sometimes. So I will be using prophylactic G-CSF in my practice. So moving on into renal cell carcinoma. These are the 3 areas that I'm going to talk about in renal cell carcinoma. One is in immunotherapy combination in non-clear cell renal cell carcinoma, and that's results of the Sunny Forecast trial. Anti-PD-1 or PD-L1 after already receiving anti-PD-L1, results of TiNivo-2, and kind of by association CONTACT-03, and then dual IO in favorable risk clear cell renal cell carcinoma. So before we talk about kidney cancer and non-clear cell specifically, we should talk about kidney cancer epidemiology and then what does non-clear cell kidney cancer even mean. So kidney cancer, around 82,000 new cases with 14,000 roughly deaths per year. Most are localized disease. This is one of those cancers that has an increasing incidence but a decreasing mortality due to early detection. And generally our colleagues in urology are the folks who take care of the localized disease. 70% is regional and 16% metastatic at time of diagnosis. 2 to 1 predominance in men versus women. Median age is in the early 60s. So clear cell is by far the most common subtype, histologic subtype of 75% of cases, papillary then in at 15%. And then you start to get more rare when you're talking about chromophobe, oncocytic neoplasms, collecting down to medullary, very uncommon. And then molecular defined subtypes, which are defined by really next generation sequencing and or FISH testing. So this is not going to go through this slide other than to say, what's non-clear cell renal cell carcinoma? Well, there's clear cell right there. Everything else is not clear cell, non-clear cell renal cell carcinoma. So it's many, many things. Now, given lots of these are molecularly defined things, and it's hard to rub 2 cases together of some of these, that's not quite accurate, but which is to say that they're not important. They are. I actually have several patients with these molecularly defined renal cell carcinomas. It's just hard to gather quality evidence on what to do for these patients because it's just hard to come across the cases to put them together. So clear cell and papillary are really the ones that have been best studied. And within papillary, that has been sort of reshuffled around. There's no longer type 1 and type 2. If you remember from your boards in the past, type 1, type 2, it's actually all one thing now. So that was changed in the 2022 WHO classification. So when we're talking about non-clear cell renal cell carcinoma, we end up using a lot of the same agents that are used in clear cell, not for any particular biologic rationale really, because these are very different from one another. But there has been actually some success in doing this because of sort of the multi-tyrosine kinase inhibitor approach hits lots of different pathways. So this is the current recommendations based on NCCN guidelines and is really outdated at this point, but cabozantinib plus nivolumab or lenvatinib pembrolizumab as a first-line metastatic regimen is what they currently say. That's the kind of where we're entering right now. So Study Forecast was presented at ESMO last year in September. It was a randomized multi-center phase 2 study. And having a randomized study at all in non-clear cell renal cell carcinoma is unheard of. You don't basically get randomized studies, at least with a real comparator arm, and properly powered. So this is a important study. It's really a tour de force in terms of the folks that put it together. But it was in first-line non-clear cell renal cell carcinoma. They excluded CNS metastasis, had to have measurable disease, and it was ipilimumab, nivolumab, so anti-CTLA4 and PD-1 immunotherapy versus standard of care. In almost all cases, the standard of care at that time was single-agent TKI. And very few patients received TKI and immunotherapy, which is kind of the real standard of care now. So we don't have a direct comparator to cabozantinib, nivolumab, or pembrolizumab and lenvatinib, but this is pretty impressive. So the primary endpoint was overall survival rate at 12 months. This table gets a little bit small, but most of the patients were papillary, about 60%, 57%. Chromophobe was next, and then we start to get into pretty rare subtypes. So the efficacy in this chart, it hit its primary endpoint at 12 months with a significant p-value and about a 10% improvement in overall survival at 1 year. None of the rest of the time points were statistically significant, but did trend towards improvement from ipilimumab and nivolumab. So when we look at markers of PD-L1 positivity, CPS is one that we look at, and it looks better if someone has 1 or higher in terms of the curves are further apart, favoring dual immunotherapy versus standard of care. So again, it's mostly single-agent TKI. When we're looking at progression-free survival, not a big difference between these, and really not seeing a huge tail on this curve, which is something that we think of with dual IO-IO therapy, at least in intermediate and poor risk clear cell renal cell carcinoma. I think they had about 2 years of median overall survival follow-up. So a lot of these events are censored, but it remains to be seen whether there's a tail on that curve, which a tail on the curve in this setting would, we would hope that those would be maybe durable remissions. So it showed a reasonable response rates across histologies. It did hit its primary endpoint of 12-month overall survival advantage. It's not clear if there's durable remissions with this regimen like there are in clear cell. I guess that there are some. The median overall survival is not statistically significant, but does trend towards ipi-nivo. It's really the strongest level of evidence that we have in non-clear cell renal cell carcinoma when we're comparing it to lenvatinib and pembrolizumab. That was a relatively large study, but single-arm KEYNOTE-B61 and nivo and cabozantinib was a very small study, CA209. So it's the strongest level of evidence that we have. It will be, I would guess, I'm not on the NCCN guidelines committee, but it should be included on the next iteration. And I have started to test for CPS in my practice for non-clear cell renal cell carcinoma. And if they're 1 or greater, I am recommending doing this regimen because I do think it's overall less toxic than a IO and TKI combination regimen. So what about well, this really should be PD-1 therapy after progression with PD-1 therapy. So this was another study that was presented at ESMO, TNEVO-2. It was a phase 3 study, and it was looking in patients that have already progressed on either first or second line therapy, and one of those therapies had to include a checkpoint inhibitor. It was looking at tivozanib, which is a relatively newer TKI at a lower dose level versus plus nivolumab versus tivozanib at the higher dose level. And as far as these curves, they do not separate from one another. They look basically the same in the intention to treat analysis. So when we're talking about safety, they actually look kind of pretty similar in terms of grade 3 adverse events as well. So the message from this was that there does not seem to be an advantage to keeping the anti-PD-1 therapy going. Basically, most of the things trend towards actually the higher dose level by itself, the higher dose level of tivozanib, maybe being a little bit better than the lower dose plus the nivolumab. So I think that the nail is in the coffin for continuing PD-1 or PD-L1 therapy after progression in clear cell renal cell carcinoma, especially in the light of CONTACT-03, which was presented at ASCO 2023. That was cabozantinib versus cabozantinib plus atezolizumab and showed the same thing, overlapping survival curves. In that case, same dose levels of cabozantinib, and all they saw were just they saw a greater amount of toxicity in the PD-1 arm, PD-L1 arm. So it's just not a good therapeutic strategy for most patients to continue the PD-1 therapy. Patients are sometimes hesitant to go off of it because they associate immunotherapy with potential for durable remission. And so that can be a challenging thing to discuss, that we have data now in this space. So does that lesson apply to non-clear cell? No, not directly, but I think this has not been a successful strategy in any cancer to my knowledge, even melanoma, but not in lung cancer, not in clear cell renal cell carcinoma. And then finally, wanted to go through the CheckMate 214 update, which is in clear cell renal cell carcinoma. So this, to remind you, CheckMate 214 is not a new study. This is an old study, but now has a median follow-up of 8 years. And so they presented an update because there are some interesting findings from this. So this is a study of over 1,000 patients in first-line metastatic clear cell renal cell carcinoma. And it was ipilimumab and nivolumab, so the same regimen we just saw in study forecast, versus sunitinib, so one of the sort of originals. So ipi-nivo was approved based on this study for IMDC intermediate and poor risk, based on superior overall survival and response rates, but it was not approved in favorable risk because it didn't look so good in favorable risk. Specifically, the PFS looked terrible. That's sunitinib looking much stronger than IO with ipi/nivo. And so that was what read out first, and that was, people said, okay, that's not the right regimen to use for favorable risk based on that. Well, with 8 years of follow-up and looking at overall survival, it tells a little bit of a different story. So now looking at the favorable risk, we see kind of the sunitinib being on top, and then we cross over here at the 4.5-year mark, and from there on out, ipi/nivo is actually better. So a little bit of a surprising finding. I guess not too surprising if you think about TKIs and how they work, is that you're not going to get durable remissions with TKIs, or very, very, very rarely. I have seen it a handful of times, but that's just not going to happen very often. And so for the people who respond very well, they can respond for a long time with a dual IO regimen. Now, why is that so different from the intermediate poor risk? Well, for a variety of reasons that have to do with the underlying biology between favorable risk versus intermediate and poor risk. But nonetheless, I think that the conclusion from that is that it is a reasonable regimen in favorable risk. So it's a reasonable regimen now in all risk categories in metastatic clear cell renal cell carcinoma. I think something to point out is where's the tail on it? So tail is, we're seeing in an intermediate and poor risk, man, 8 years out, we still have 25% of patients that haven't progressed. They haven't died, they haven't had progression. That is, that's something that people are really interested in, and it doesn't seem to be there in the favorable risk. So I'm not sure if we're getting the durable remissions at the same rate, but we are seeing a survival advantage overall. Again, compared to sunitinib, so not something that we would use in modern times, but it was the comparator that all of the registration trials for the first-line regimens have used. So I think that it's really a choice of between different toxicity profiles on which regimen you recommend to your patients for favorable risk first line. Show my references. Thanks for your attention. Sure.
Hi, VK Gotti. I'm actually a breast medical oncologist, so forgive me.
Sure.
On the Trophy-4 study,
Yeah.
One of the
Tropic-4, yeah.
Tropic.
Trophy, and then Tropic-4 was the confirmatory, yeah.
Okay, yeah. So in the confirmatory trial that was negative with the excess dates, just one question and then one comment. The question, how many of those excess deaths were actually related to neutropenic complications?
The majority of them, I think it was like 17 or something like that out of the 25.
So something I learned this from community colleagues, and I actually started doing this in my own practice, which is just to go with Q2 week dosing. And I find many patients don't even need growth factors in that setting, and I'm not actually seeing a loss of benefit in those patients. So I don't know if that's a study strategy that could be considered. I know it's a different drug with a different linker, but sacituzumab torumantecan is actually going to be developed with a Q2 week schedule as well. So it seems like other people are thinking about this in this way.
Yeah, no, I think that's an interesting. I didn't know that. I think that in hindsight, people wish that the prophylactic G-CSF would have been mandated. Different dosing strategies certainly could be thought about. Diarrhea and neutropenic fever are the two things that we really see a fair amount of with that agent. And so I think there is efficacy there. I think there is a role for it in bladder cancer, but I'm just not sure what it will be now with the negative phase 3. So I think there is still interest in, there's ongoing studies using it. Will it get reapproved? Will it be a different agent that gets introduced? There's a lot of work in bladder right now with antibody drug conjugates. It's sort of a hot area of development, and so we will see some of these agents. Will it be sacituzumab? I don't know. Thank you.
Other questions? For frail patients with bladder cancer, what is your choice? You cannot tolerate high-dose chemo?
In metastatic disease or in muscle invasive when they're potentially curable? Well, that's a tough one. If they have the right characteristics for bladder preservation, I think that can be a really attractive option. That's what ends up happening a lot of times, even though I think that option should be presented to potentially every patient with muscle invasive bladder cancer is bladder preservation with maximal TURBT plus chemorads. Allows people to potentially keep their bladder. There are certain scenarios where that is absolutely not appropriate. Bilateral hydronephrosis, certain very large tumors, multifocal disease. It doesn't necessarily have the best track record in those cases. But the urologists are the folks who tend to have the first patient contact, and that is the gold standard, cystectomy. And so for a frailer patient, sometimes they're not a good surgical candidate. It's too risky. It's a morbid procedure. And so those are the folks that we often see coming to us specifically to talk about bladder preservation. And we've had a pretty good, there's no good head-to-head studies, but they tried and it didn't enroll because people don't want to be randomized to having their bladder out versus not having their bladder out. But it seems to have relatively, in the right patient population, similar outcomes in terms of cure rates and whatnot.
Thank you.
No one wants to take you up on questions. In the Checkmate study where you saw in the favorable risk patients, the OS curves flip eventually over time.
Yeah.
Is there a chance that the TKI exposed patients were then crossing over to IO agents and that actually led to a more rapid decrease in their survival?
So I think the patients that were on single agent sunitinib, many of them did receive IO therapy at some point. I don't remember the numbers off the top of my head. I think that might be in an appendix somewhere, but not everyone. And so I think that at this point, all the data really is for using it in early, basically as a first-line agent and then dropping it later. And so I think that's it's an interesting question, but at this point, there's different molecular sort of defined subtypes of clear cell renal cell carcinoma, and the favorable risk group seems to have a larger subset that has sort of this angiogenic profile that's very sensitive to like VEGF agents, which is sort of what most of these TKIs are working on, in addition to other pathways. And so you see really great response rates. You see really good relatively good PFS, but there's something about getting this regimen first that allowed those patients, even though they progressed much sooner on average or on median, to do well in the long run. So I think that speaks to the immunotherapy, modulating the immune system for much longer than just the duration of therapy even.
Great. Thank you, Dr. Westbrook, for a great talk. So our next speaker is Dr. Mohammed Antique. He's an assistant professor at the University of Chicago. His focus is on prostate cancer, and he will be giving us an update in treatment options for prostate cancer. So welcome, Dr. Antique.
All right, I'll make sure everyone can hear me okay here. So go ahead and, sorry, I'm gonna grab that. Okay, great. So today I'm gonna be talking to you all about personalized medicine and prostate cancer. So these are my disclosures, none of which are for any of the companies that, or any of the topics that I'm talking about today. Okay, so I'll start with a little bit of background on the subject matter at hand, and then I'll get right into a kind of discussion of PARP inhibitors, going over some of the more recent studies from the past year or two here in relation to this. Then I'll get into a discussion about PSMA radioligand therapy, and talk about, or close up with talking about some new targets in development. All right. So when thinking about prostate cancer and personalized medicine, so we have to remember that there are clear indications for germline genetic testing in prostate cancer. So some of these are based on tumor characteristics, such as when patients have localized high risk or more advanced disease. Also based on history. So if someone has a positive family history or personal history themselves of breast cancer, as well as Ashkenazi Jewish ancestry. Additionally, there's clear indications for somatic mutational testing. So this can include those with regional lymph node disease or metastatic hormone-sensitive disease, looking specifically, for patients with HRR gene mutations, as well as MSI or DMR status. And then while that can be considered, it is clear that we do testing in patients with castration-resistant disease. And so again, looking for these HRR genes, MSI status, or TMB mutational status. One thing I'll go ahead and say is that I may interchangeably use a couple of terms here. It's not meant to confuse you, but so MCRPC or CRPC, talking about metastatic hormone-sensitive or castration-resistant prostate cancer, or NHA, ARPI. These are novel hormonal agents or androgen receptor pathway inhibitors. So just something to kind of keep in mind as we go forward. So today's talk is mostly going to center on patients in the metastatic, or treatments in the metastatic castration-resistant setting. So this is defined as testosterone less than 50 nanograms per milliliter. So patients who have that and who also have conventional imaging that demonstrates metastatic findings. And so this would be CTs and bone scans. Now we do have new imaging in prostate cancer, PSMA PET scans, and so that's kind of thrown a new sort of interesting dynamic to what we do. But this is the classic definition of metastatic castration-resistant prostate cancer. So in this setting, about 20 to 25% of patients have DNA damage repair mutations, as demonstrated in a paper by Robinson et al. And so these include mutations such as in BRCA1, BRCA2, ATM. The prevalence of these DDR mutations has allowed for the addition of PARP inhibitors to the MCRPC landscape. So the first of these approvals came with olaparib via data from the PROfound study. So some of the select data shown here. So this study took MCRPC patients who had progressed on prior novel hormonal agents and who had DDR mutations, and then randomized them to olaparib monotherapy or another novel hormonal agent. In this case, abiraterone or enza was kind of the choice there. The study was mostly comprised of patients with BRCA mutations and showed improvement in PFS and OS for those patients as demonstrated in the curves here. But it should be noted that there was also an improvement in OS for a second cohort of patients who had other DDR mutations, although not as robust. The second PARP inhibitor monotherapy approved for MCRPC was rucaparib. So this was done through the phase 3 study of the Triton series of studies, so Triton 3. So this had rucaparib versus a physician's choice of ARSI or ARPI switch, as well as chemotherapy. Improvement was demonstrated in rPFS in the BRCA1 and 2 patients. So based on the 2 studies that I've presented here, PROfound and Triton, we know that PARP inhibitor monotherapy improves overall survival in HRR mutated MCRPC that has been pretreated. But what we really didn't have data on was what if there was an additive effect or synergistic effect from combining PARP inhibitors with these ARPIs, and that's where the series of trials I'm about to present comes into picture. So now I'm going to segue into the latest studies on PARP inhibitors that have moved these drugs to combinations earlier in the MCRPC setting. So the first study I'm going to talk about here is PROPEL. And so this trial took first-line MCRPC patients who had not received any prior abiraterone and randomized them 1-to-1 to abiraterone or olaparib. Patients were allowed to have received chemotherapy in the hormone-sensitive setting. The primary endpoint was rPFS, with OS being a key secondary. Importantly, though, the HRR mutational status was assessed after randomization, so determined retrospectively here. So the baseline characteristics of the patients on the study were fairly balanced. Around a fifth of the patients in the study had received prior docetaxel, although not shown in this table, but demonstrated in other data related to the study. Less than 1% of patients had received a prior novel hormonal agent. And then the HRR mutated population itself comprised just shy of about a third of each arm. So the primary endpoint of rPFS favored abiraterone plus olaparib as compared to the Abi monotherapy arm, with that rPFS being somewhere around 25 to 28 months over the monotherapy arm being around 16 months. So when the overall survival for the Abi PARP inhibitor arm, or Abi olaparib arm, versus Abi monotherapy arm was analyzed by the HRR mutational status, so there's a much greater difference in the median OS of the HRR mutated patients with a hazard ratio of 0.66 as compared to that of the non-HRR mutated patients with that hazard ratio being closer to 0.89. So this suggests a larger benefit for patients with HRR mutations who received the combination compared to those without. Moreover, one of the issues with the overall survival here is that current data available suggests less than 1% of the patients in the study who did not receive a PARP inhibitor went on to receive it. And so this leads to the question of what the HRR mutated overall survival would look like if there was a crossover arm. And those patients on abiraterone only, which included HRR mutated patients, could have received a PARP inhibitor. So you show basically here that HRR mutations, or HRR mutated patients who had not received a prior ARPI, that adding olaparib to that improves their overall survival. But what you don't show here is whether or not sequencing these therapies or combining them is superior. So the next study I'll talk, and that's going to be kind of a theme of sort of these studies I'm presenting here for the most part. So the next study I'm going to talk about is TALAPRO-2. So this was a pretty similar study. Again, at ARPI, enzalutamide here versus talazoparib plus enzalutamide. So basically this was, again, first-line mCRPC patients, randomized 1-to-1 to talazoparib plus enzalutamide versus the ARPI and placebo. Primary endpoints are the same, rPFS and OS. An important difference, though, is that patients on the study were prospectively assessed for their HRR mutational status and included a pretty broad list, which is here in this red box. Include that list outside of BRCA and ATM, so also had CHEK2, PALB2, CDK12, et cetera. No prior enzalutamide was allowed on this study, so again, similar design there. The baseline characteristics also fairly equivalent, so around a fifth of the patients here had received docetaxel, only 6% had received a prior novel hormonal agent, and the HRR mutations comprised around a fifth of the population, so as denoted here in the red box. The primary endpoint of rPFS favored the talazoparib arm with a hazard ratio of 0.63. I believe there was a press release about some data coming out with overall survival, but I don't believe the data itself has been released yet, so that, still awaiting to see that. Further examining the rPFS data by HRR status and focusing on the HRR deficient population, what you can see is a much larger difference, again, in the two arms with a hazard ratio of 0.46 as compared to that of 0.70 in the HR non-deficient population. So similar to PROPEL in that sense. So data so far that has been presented suggests around 17% of the patients in this study went on to get subsequent PARP inhibitors. So again, this answers the question, the question answered here more thoroughly is that those with HRR mutations benefit most from using a PARP inhibitor. The third and final PARP inhibitor study that I'm going to talk about is MAGNITUDE. So this study was a little bit different from the other studies. Now, again, we do have a novel hormonal agent, or ARPI, plus a PARP inhibitor here. And mutational status was prospectively assessed, but initially the study started out with a HRR mutated and a non-HR mutated cohort, and then randomized patients within that to niraparib and abiraterone, or abiraterone alone. So you had 2 cohorts, and then each cohort randomized to each arm. However, the non-HRR mutated cohort was then closed during the study due to futility. So then the study just proceeded with the HR mutated cohort. These patients, it should be also known that these patients are further stratified. So you see how it kind of splits into BRCA 1 and 2. So this is kind of the more updated design after they had kind of closed the initial cohort due to futility. But you can see that patients then, after they're randomized, were also stratified then into BRCA 1 and 2 or other HRR mutation categories. So the study, the study largely mirrored the prior studies with the exception of it continuing on with HRR mutated patients. But also importantly, having a particularly large representation of BRCA 1 and 2 patients. So this is kind of close to over 50% up here. As you can see, 53% BRCA 1 and 2 patients in this, under the second box here. Sorry, I'm not going to attempt to use the laser pointer. I'm just good enough with the arrows right now, unlike Dr. Westbrook. But basically, you can see that there's a large percentage of the BRCA 1 and 2 patients here. So if you go back to like PROPEL, for example, then that percentage shown in the prior slide was closer to around 10%. Additionally, so also similar to these other studies, only a small percentage of patients had gotten a prior novel hormonal agent. So the benefit seen was most pronounced in the BRCA mutated subgroup, and this is what was shown here on this slide. The RPFS of the BRCA mutated patients favored the niraparib arm at 19.5 months versus around 10 months for the Abi monotherapy arm. And so in addition, there was also a measure of time to symptomatic progression in the BRCA subgroup, which again favored the treatment arm. The RPFS reported in the total HR mutated population did favor niraparib Abi with a hazard ratio of 0.76. But again, we're talking about big differences when we're looking at, we're talking about a bigger difference with the BRCA mutated group than versus this other population. There was also an additional reduction seen in the risk of needing chemotherapy and a trend for improving overall survival in the treatment arm as well. So when we think about all of these different PARP inhibitors, and so we're looking at kind of adverse events. So for the most part, when we're talking about all grades, the most common events here tend to be hematologic, so anemia, neutropenia, fatigue is pretty common as well. And then others, frequent occurrences can include GI side effects as well. The most severe AEs tend to be anemia or hematologic as well. So PARP inhibitors gained approval in combination with ARPIs and BRCA or HR mutated mCRPCs. This was all in 2023, and this is kind of shown in order here. So based off PROPEL study, then niraparib and abiraterone can be used in mCRPC patients who have BRCA mutations. And so I just had some characteristics of the studies underneath, just as reminders here. TALAPRO-2 then allowed for the approval of talazoparib plus abiraterone in the HRR mutated population. So if you remember, it used a pretty or broader sort of brush to paint, include HR mutations there. And then magnitude left for niraparib and abiraterone, the BRCA mutated population. So a key question here raised from these studies, and I kind of alluded to this earlier, is an ARPI or novel hormonal agent plus a PARP inhibitor combination better than sequencing these? And so this is something that is somewhat answered by a smaller phase 2 study here, or at least given some information on this phase 2 study of BRCAway, which looked at abiraterone, olaparib, or abiraterone plus olaparib. So this allowed for abiraterone and PARP inhibitor naive patients who had not received chemo in MCRPC and had a BRCA1/2 or ATM mutation, so germline or somatic. Patients were randomized 1:1:1, so between either of the monotherapy arms, abiraterone or olaparib, or the combination arm of the two. Those on the single treatment arms could cross over. So an important aspect of the study, and then the primary endpoint was rPFS. So the qualified group ended up being around 61 patients between the three arms, and so it seemed that the combination arm had more patients with visceral mets, although the abiraterone arm had more patients who had previously received chemo in the MCSPC setting, so there was thought to be some balance between the disease severity in these patients. In terms of efficacy, you can see the median PFS was markedly longer in the arm combining abiraterone and olaparib as compared to the other two arms. Similar number of patients crossed over from the abiraterone prednisone arm to the olaparib arm and vice versa. But interestingly, the median PFS from the time to randomization was identical. So this study then suggests that one should consider a combination approach of PARP inhibitor plus abiraterone in frontline ARPI and PARP inhibitor naive MCRPC patients with a BRCA1/2 or ATM mutation. However, again, the primary unanswered question from the study is what do we do when a patient progresses on an ARPI in the prior hormone-sensitive setting, right? So this was, again, hormone-resistant prostate cancer that had not been exposed to ARPI, but our question still remains, well, what do you do when a patient is exposed to that? And that's more relevant to our US population, where almost every patient, or at least a large number of them, are going on ARPI. There's obviously real-world evidence that says maybe some people are still being treated with singlets, but generally speaking, most of what we see, people are at least getting a doublet and usually an ARPI with that. So my takeaways for PARP inhibitors. So the way that I look at this data and then analysis of the three studies there, and then with some of that using the phase 2 study there to kind of support more of my approach as well, understanding that's a smaller study, smaller numbers, but we use the data we have with us and go from there. So I think that my takeaways are that patients with HR mutated MCRPC should be considered for treatment with combination ARPI and PARPI inhibitors. Or PARP inhibitors, sorry. You can still use PARP inhibitors as monotherapy, post-ARPI or post-taxane in patients with MCRPC who have DDR mutations. So instead of using the combination with ARP or switch, you could always use that later, or you're able to use that later. You can also then still use this, say, if a patient had received a triplet routine in the hormone-sensitive settings. So the next area of precision medicine in prostate cancer that I'm going to talk about is PSMA radioligand therapy, and I'll first start with lutetium PSMA. So first we need to answer what is PSMA, right? So this is prostate-specific membrane antigen, and so this has led to an era of theranostics in prostate cancer. So this is a transmembrane glutamine carboxypeptidase. It's internalized when liganded. There's near universal expression, so a very small percentage of prostate cancer patients tend to be PSMA PET negative, although yes, expression can be heterogeneous, and so this is something that we can see when we talk about mechanisms of resistance. But again, near universal expression, and then that's also seen to increase with later stages of the disease. So this made its way, or this PSMA radioligand therapy made its way into prostate cancer with lutetium via the VISION study. So these were MCRPC patients. They had been post-taxane chemotherapy and a prior ARPI. They all had to importantly have PSMA PET positive disease. And so they were basically randomized to lutetium, PSMA, plus the standard of care. And that was kind of left to sort of investigator discretion there, but the trial itself specified that the standard of care had to basically be an ARPI versus just an ARPI switch. Primary endpoint here was overall survival. And so the end result of this study is that there was a improvement in overall survival. And so now PSMA lutetium has come to a standard of care post-ARSI and post-chemotherapy, so it has its approval there in that setting. Important things to note are kind of the AEs here, so fatigue, anemia, so this kind of relates to the radioligand treatment itself and some of its off-target toxicity. Other frequent AEs and what we think about particularly, which relates to expression of PSMA, is dry mouth. So we know on PSMA PET scans, one of the ways you know maybe the scan is actually good is you should see salivary gland expression. And so it's not surprising that then using something that targets PSMA can cause dry mouth. So in addition to its established role in the post-chemotherapy setting, so lutetium PSMA is also being brought forward to the pre-chemotherapy setting. So for MCRPC patients, so this is being tested here as shown in the PSMA-4 study. So it basically uses the same, the beta emitter lutetium, uses the same ligand of PSMA-617, but now this is just being done in a pre-chemotherapy setting. Patients are treated with the same dose, so at 7.4 gigabecquerels of treatment, and getting 6 cycles of this. So they're either randomized to that or ARPI switch, and there's crossover allowed on this study. So the data presented from this study at ESMO had shown an improvement in rPFS pre-chemotherapy, and so now this is pending an FDA label. So you know this, like all treatments in other settings, started later, is now starting to move earlier. Now, I do want to mention a second study here. So this is another pre-chemotherapy PSMA radioligand study. So again, using the same beta emitter lutetium, but uses a different ligand. So this is PSMA-INT or PNT 2002, whichever one you want to call it. But basically uses a different ligand here, has essentially the same design. So MCRPC patients, pre-chemotherapy, patients are being randomized 1-to-1 here. The difference is that because the ligand is different, then they are using a lower dosimetry. So the patients here are treated at, I believe, 6.8 gigabecquerels for the lutetium PNT combo here. And then this is given every 8 weeks. This study itself, so the primary endpoint, while rPFS did favor the treatment arm, it was noted to be less of a benefit compared to the previous PSMA-4 study. And so part of this is thought to be that, again related to dosimetry. Also, that should be noted is, so, you know, the intention behind using this INT or using a different ligand was the idea that this ligand is taken up much more quickly into the tumor. It also has a shorter half-life. So then the thinking there is that, okay, well, maybe you could get away with a lower dose of, or use a lower dosimetry here, and that's why that was kind of spaced out. And then hopefully maybe you'd also see less side effects, although when looking at kind of the AE table they had presented, so some of the notable things, particularly again, if we come back to dry mouth, for example, there really wasn't that much of a difference when you tried to look at the percentage of patients who end up experiencing an AE on that side. So my takeaways for PSMA radioligand treatments, lutetium PSMA radioligand therapies are effective post-ARPI and taxane, or you can also use for taxane-ineligible patients. And this is likely going to follow soon to the pre-chemo space. So once there's that FDA approval is approved there. Sequencing is still a question to be answered here. So there was a study called Therapy which looked at PSMA lutetium and then versus cabazitaxel. Really no difference in overall survival benefit seen there, although there was an improvement in quality of life. But still, with all these different options coming into the space, understanding what to use and when is going to still be something we have to answer, and is very dynamic in the patients we see. So knowing that this is a heterogeneous state, while you can have a generalized approach, which I'll attempt to do on one of these subsequent slides, it's always with disclaimer that you have to always look at the patient in front of you. Trends for this, so it is going to be moving earlier. So in red are some of the settings in which we're opening studies at Chicago that are using lutetium PSMA. And so these are studies that are opening around the country. So in the neoadjuvant setting, in oligometastatic hormone-sensitive disease as well. So they're in kind of a ADT sparing approach, which obviously a lot of our patients have a big interest in. And then just in metastatic hormone-sensitive disease as well. So there are a couple of studies ongoing. So PSMA addition, upfront PSMA, which are looking at that. Finally, talking about PSMA radioligand treatment. So, if you notice on the slides I presented, all of these were about using the isotope lutetium. So that's a beta emitter. There are other isotopes that are also being tested. So for example, actinium-225, so an alpha emitter. So different features to that, but also other isotopes being used in combination with PSMA. So my approach to MCRPC. So when I have a patient who comes to me and they have metastatic castration-resistant disease, so this is at first point of contact. So the way that I look at this is first obtaining somatic testing. So we know there's therapeutic implications from this, and that obviously justifies the rational approach to doing that. If a patient has a DNA damage repair mutation, then I'm looking at going to a PARP inhibitor with an ARPI combo. And while we don't have an answer to about if one should do an ARPI switch or not, the way I kind of look at that is, well, one, is the patient tolerating that ARPI if they were on it before, right? So do they have significant side effects or problems or issues from that? Two, financial toxicity as well to the patient. What good's a treatment if a patient can't afford it? So that's something that we do have to think about in these cases. But generally speaking, all things aside, drug interactions aside, other things, I look at also considering an ARPI switch in this situation. Now, there are different PARP inhibitors that, we didn't get into kind of some of the preclinical data on this. There's different PARP trapping mechanisms, thoughts related to maybe the efficacy of the treatments. And that's kind of another topic altogether. And we need different studies to be able to really say what's superior to one another. But still, I look at doing a PARP inhibitor with ARPI. If there is no DDR mutation, so MSI high or TMB high, now that is something that I do keep in mind. If a patient has received a prior taxane, that's something I at least discuss with them. When we look at prostate cancer and as far as the data we have on MSI high and TMB high responses, TMB high doesn't really seem to be a great marker of response there, at least from the data and studies that we have available to that. So looking most recently at a publication out of Memorial, MSI high seems to at least give us a better indicator or at least predict better response. But these are things that I at least discuss with the patient there. I don't necessarily go to that. It just kind of depends a little bit on comorbidities and other issues with the patients. If there are no mutations, then docetaxel is one of my first choices here. Now that's assuming the patient hasn't received docetaxel in the hormone-sensitive setting. So that's kind of a key thing that I sort of keep in mind there. There is a concept of docetaxel re-challenge in metastatic castration-resistant prostate cancer. But again, re-challenge is something that I save for a later time if needed. I don't go just back-to-back docetaxel. Obviously, that doesn't make a lot of sense scientifically. But docetaxel aside, then PSMA lutetium is what I look at next. So again, I look at, okay, well, that and cabazitaxel are considered to be similar in overall survival, but this has potentially better quality of life. Also has clearly a different mechanism. If their PSMA PET scan demonstrates the biomarkers there, then I'll use that treatment and then keep cabazitaxel. Now, the caveat to all of this is that if there's an appropriate clinical trial, I offer it, right? So this is part of the reason when I was talking about pembrolizumab that I don't necessarily just default to that. There are studies that are ongoing that look at using checkpoint inhibitors in combination with treatments in the setting. And so if you have something, if you have a trial that's appropriate for your patient, then definitely that's where I go first. So some of the targets in development. And so these are just some. This isn't an exhaustive list by any means. So again, with PSMA, so we have a great way of looking for this biomarker with our PSMA PET scan, so a great target there. Some of the modalities include bispecific T-cell engagers, CAR T approaches as well. So these are all kind of in the earlier phases of study. STEAP is another target, so 6 transmembrane epithelial antigen of prostate. So again, bispecific T-cell engagers in CAR T, and then PSMA STEAP ADCs as well. So those are coming, or bispecific ADCs, which are also being explored in the prostate cancer setting. B7H3, so that's an immune checkpoint protein, and so there's monoclonal antibodies and T-cell engagers being studied for that. And then KLK2, so a protein expressed more in prostate cancer, and some modalities include actinium-225 being combined with this, another radioligand. So the ones in red here include studies that are opening or have opened at U Chicago. With that, I'll conclude. Thank you, everyone.
Questions?
Thank you, Dr. Hatik. On the breakaway trial, I know that was a small study with very few patients per arm. I was a little confused. Was PFS2 reported after crossover, or did they just record crossover and do you just show the PFS just straight up? Is that what was shown? I didn't quite follow.
Yeah, so you're saying, yeah, so after, or when they looked at those 2 arms, did they report a second PFS for that? Yeah, so that's what they showed, kind of a second sort of PFS after crossover.
And the gap didn't close. In other words, they never caught up.
So those did not catch up. No. Yeah.
Great talk. For your own practice, when you're seeing patients that have, particularly when looking at Pluvicto, when you're considering patients and you're doing PSMA PETs, and you're seeing lesions that do not light up, that are thought to be prostate cancer, do you recommend doing Pluvicto to those patients? Does it depend on where those lesions are? Does it depend on the extent of it? Because I think in the original VISION trial, they had both FDG PETs and they had PSMA PETs, and if they were PET discordant in that they were PSMA negative but FDG positive, they excluded those patients. So in practice, the FDA labeling patients, if they have one lesion that's PSMA avid, technically can get Pluvicto, but should they get Pluvicto?
Yeah, so I think that, so we kind of come into like the heterogeneity of the disease. And so we think about, patients, so if we're looking at the patient as a whole, and, if there's, and it kind of also depends on, as you kind of alluded to here, kind of where that sort of met is. So if I have someone, with liver metastasis, that's obviously a patient who's not going to do well. And so that's a patient in whom, if that is not really lining up, then, what benefit am I necessarily providing by going for the other lesions there when the most kind of life-threatening or serious disease is not being really addressed? I look at that kind of like case-by-case basis. I actually had a case where there was a patient who had prostatic adenocarcinoma and then a transformed small cell neuroendocrine carcinoma as well. So had that biopsy confirmed, had PSMA and FDG scans done. Now these were concordant, interestingly enough. So for that patient, okay, well there's biomarker and it's in his disease and then there aren't sites that aren't there. Yeah, I'm going to go for it. But yeah, I think it depends on sort of where those lesions are and then kind of like and then also kind of the overall burden I'm seeing there. So again, I kind of look at that, okay, well, if, there's, a lymph node here or there or something like that, okay, well, I guess that doesn't really necessarily mean PSMA PET negative. But, I don't really necessarily just go strictly by exactly as kind of how the study did. So I kind of look a little bit more at that heterogeneity.
More questions? Anybody? About the bone marrow reserve, these patients, considering have received many cycles of chemotherapy, do you have any thresholds of count to administer the radioligand?
Yeah. So that's a great question and kind of something that we're going to increasingly encounter in these patients. These are older patients, so that's kind of prostate cancer in general, right? Most of the patients are over the age of 65. I say older, a little bit of caution here, but these are patients who have also typically received a lot of treatment too. So we're looking at kind of baseline cutoffs to get started and also looking at treatment options I look at the patients and I look at kind of what their marrow, so if it's just anemia, for example. So we know by being on hormone lowering therapy or testosterone lowering therapy, then your red cell mass will naturally decrease in response to that. And so for that, typically, yeah, we're looking kind of cutoffs around, hemoglobin 9 or so. But I don't necessarily keep a strict cutoff. And there's part of the reason for that is so, if a patient's coming to me and they don't really have a lot of treatment options, then one of the things that you have to look at is what counts are affected and what are the risks of what you're doing to the patient. And also, could their counts be affected because of the disease? Right? So we know that people who have very aggressive prostate cancer, that can affect the bone marrow and their reserve as well. But I would say that I'm also looking at kind of what changes. So if I do a cycle of treatment and we're evaluating those patients or getting labs on them every 3 weeks, and so I'm looking at kind of the baseline and then where's that baseline shifting in response to treatment. So you obviously have a frank discussion with the patients about the risk of bone marrow failure, about the risk of hastening an unfortunate process there in terms of shortening their life. But at the same time, while I have general cutoffs in mind, if patients are somewhat close to say that sort of hemoglobin threshold, platelets over 100,000, no other significant issues, then still consider the treatment if need be.
Thank you. Thank you, Dr. Atik. So now that we're updated with clinical management, our next speaker is Dr. Neha from UIC. She's our famous chief fellow. So please welcome, and we're going to have a case about GU malignancies.
Can you hear me? All right, great. Good afternoon. I'm Neha Hippelgaunker. I'm one of the third-year fellows at UIC. Thank you all for having me. So I have been tasked with presenting a couple of cases that hopefully will apply what we just learned and hopefully not terribly redundant. So the first case I'll be talking about in the metastatic bladder space, and then the second case will be a metastatic prostate cancer. So the first case is a patient, a 74-year-old gentleman with a history of metastatic urothelial cell carcinoma who presented to our clinic for follow-up, and upon seeing him in clinic appeared to be pretty considerably short of breath. Vitals at that time showed O2 sat of 65%. So quickly got him over to our emergency room where his sats started to improve. While he was there, he was also febrile and then eventually stabled out on 4 liters and was 88%. He had noted at that time that he had been feeling progressively short of breath over the past week or so, noting that it was getting gradually worse. Also endorsed a productive cough as well as subjective fevers and some chest pain. So to just review a brief oncologic history for this gentleman. So he initially was diagnosed a year prior with hematuria, was found to have a bladder tumor. PET CT at that time did show metastatic disease involving the omentum, a portal node in the liver, like I said, concerning for metastatic disease. At that time, he was offered first-line treatment at that time, which was GEM and CIS, for which he had 3 cycles. On repeat of his CT scan, he did not have any disease in his chest. However, a necrotic mass was seen in the left nephrectomy bed. I'll mention he had RCC several years prior, as well as destruction of the L1 vertebral body and an increase in size of the mesenteric soft tissue deposits. So with that, we discussed next line treatments with the patient. Our recommendation was EV Pembro. The patient at first was a little bit concerned, so we just did single agent pembrolizumab, and then after 3 cycles of that, we were able to add on the EV portion. He did quite well with that, and on the other side of the slide, you see his primary oncologist, in addition to getting scans, was also getting routine ctDNAs just to see our progress with treatment. So as you can see, started off with a level around 600, and then more recently came down. It was still positive, but positive below the analytic range, so telling us we were heading in the right direction. We did repeat scans most recently and noted that there is no new disease. However, in the lung bases, there did appear to be some minor airspace disease. And then the patient had started to develop some neuropathy, and so we did dose reduce his EV from the 1.2 milligram per kilogram to 1 milligram per kilogram. So in the AED, his physical exam, pertinent things being the fact that he was in respiratory distress. His lung sounds both were decreased, left worse than right, but beyond that, no evidence of fluid overload or anything else significant. His labs are also pretty unremarkable. His lactic acid was 1.5. He had a slight leukocytosis to 13.4, but beyond that, the rest of his labs looked fairly benign. So in the ED, they got a chest x-ray, which looked pretty impressive, had some increased patchy and nodular airspace opacities that were scattered throughout the bilateral lungs, which was concerning for a multifocal pneumonia or worsening metastatic disease. The ED also got a CTA-PE to evaluate for pulmonary embolism. Thankfully, he did not have that. However, there was interval progression of multifocal consolidation, nodular, and ground glass opacities throughout the lungs, more pronounced in the left upper lobe. The differential at that point was obviously infectious versus something inflammatory, and could also consider metastatic disease. So he was admitted to our inpatient service due to concern for pneumonia. Of course, he was started on pretty broad spectrum antibiotics. Eventually, we were able to de-escalate that. However, on the 5th day of his hospital stay, he noted to have worsening oxygen requirements. He required high flow nasal cannula, and then we did a repeat CT, which showed that he had progression of these interstitial findings as compared to his CT on admission. He was eventually admitted to our ICU, and at that point, our biggest differential, at the top of our differential, was a immune checkpoint inhibitor, pneumonitis. So he was started on steroids with 1 mg per kg. This did the trick. Eventually, his oxygen requirements did come down considerably, and then he was started on a steroid taper, and then eventually discharged home on 5 liters. So just to briefly go over some of the basics, so we discussed EV Pembro. So EV is an antibody drug conjugate, which is designed to target Nectin-4, which is a protein that's highly expressed on the urothelial cancer cell. So the mechanism is that with the binding of this antibody drug conjugate to Nectin-4 will then be internalized by this complex. Once inside the cell, the cytotoxic agent is then released, and then that will disrupt the microtubule network, leading to cell cycle arrest and apoptosis. So EV32, this was the trial that determined the approval for this as first line. It looked at EV Pembro versus our prior standard of care at that time, which was Gem-Cis. As we've seen, this is the same chemo regimen that we see in the neoadjuvant space. The difference here is that for the cisplatin ineligible patients in the metastatic setting, we also were able to use carboplatin as an option. Here is the PFS. So risk of progression or death was reduced by 55% in patients who received the EV Pembro. And then overall survival here showing that the risk of death was reduced by 53%. This is a subgroup analysis of the overall survival, further highlighting that in all of the subgroups, EV Pembro was favored. Just a brief mention about our treatment-related events as it pertains to our case. So the ones that we think of most commonly are neuropathy, dermatologic side effects, hyperglycemia, fatigue, GI side effects, cytopenias, as well as some ocular toxicities. And then with regards to EV302 and pneumonitis, as with our patient, So pneumonitis of any grade occurred in about 10% of the patients in the trial, and grade 3 to 4 pneumonitis occurred in about 4% of the patients. This is higher when you compare it to single agent EV, where pneumonitis of any grade was about 4%, and then grade 3 to 4 pneumonitis was seen in less than 1% of patients. Briefly, just to discuss some management of these toxicities. So early dose reduction is preferred with neuropathy. Again, the starting dose is 1.2. However, reduction to 1 or 0.75 at the earliest signs of neuropathy is favored. In the trial regarding diabetes management, patients that had an A1C of 8 were excluded. However, in clinical practice, we are still offering this regimen to our patients as long as we're able to control the patient's sugars. Growth factors used to help with our cytopenias, topical steroids, and dose reduction for skin rashes, and then just being aware of what to look out for ocular toxicity. Most commonly, 30% of patients will have some sort of dry eyes. And I know Dr. Westbrook already mentioned this, but just kind of thinking a lot about next lines of treatment now that EV Pembro is in the first line setting, it does make deciding subsequent systemic therapy difficult. And with that, I will switch over to our second case. So this is an 89-year-old gentleman with a history of metastatic CRPC with involvement to the bones. He was initially diagnosed 10 years prior. His initial pathology was a T3A N0 disease. He completed radiation therapy after his initial surgery and then was eventually initiated with Lupron and started on apalutamide. His outside oncologist had noticed that he was having increased PSA, got a PSMA PET, which then showed his osseous disease progression. So then he saw us in clinic and he was started on abiraterone and prednisone. However, within a month or so of seeing him, we noted that his PSA continued to rise. We did perform germline testing after first seeing the patient, and we noted that the patient was in fact positive for, he had a pathogenic variant in the ATM gene. So this is a gene that's involved in cellular response to DNA damage. It's a loss of variant function with this mutation. And then also noted he had a variant of unknown significance, or a VUS, in CHEK2. So this is a graph of the patient's PSA. So when we first started him and initiated him on abipred, he was around 3. As we were working him up, we noticed that he peaked around 14, which is when we added the addition of olaparib to his ARPI, and then started to notice a nice downtrend in his PSA. I'm happy to report we saw him recently and he's doing well. So I know Dr. Atik also mentioned this briefly, but this is basically just showing us the changing landscape in metastatic CRPC patients. These are the list of the trials that we've already heard a bit about, but helping us kind of shape what we do next. This highlights the importance of identifying patients for PARP inhibitor therapy, particularly those with BRCA1 and 2 mutations. Just to, again, go back to the basics a little bit, this is the homologous recombination pathway, which is crucial for the accurate repair of DNA double-stranded breaks, which primarily occurs in the S and G2 phases of the cell cycle. The key proteins, which we are mostly all aware of, is BRCA1 and 2, RAD51, and then this MRN complex. The MRN complex, when in the pathway, it works by resecting the DNA at the double-stranded break, and then it recruits ATM, which phosphorylates CHEK2, which then recruits this BRCA complex, whose role is then in DNA synthesis and in repair. So obviously, when we have a deficiency in this pathway, then we will get impairment. This slide is really just showing us that these mutations are quite prevalent in prostate cancer, about 6% in the localized high-risk space. 11.8 germline mutations are seen in the metastatic space, and then 20% somatic mutations in advanced disease. So this is the trial, the CAPTURE trial, and this provided prevalence and outcomes of BRCA1 and 2 mutations in the prostate cancer patients. About 13.2 of the patients, or close to 7,300 patients, were seen to have a BRCA1 and 2 mutations, and the outcomes for these patients were significantly worse when compared to those without the mutations. Endpoints included radiographic PFS, PFS2, and overall survival, and these were all significantly shorter for these patients. Specifically, mutation carriers had worse outcomes in all measured parameters as compared to non-HRR and HRR non-BCRA subgroups. Again, kind of underscoring the importance of early screening for these mutations. And then just to talk briefly about the mechanism of PARP inhibitors. So these mutations in these genes can lead to HR deficiency, which we know are associated with increased susceptibility to cancers. However, the HRD can be exploited therapeutically by targeting these cancer cells deficient in the HR with PARP inhibitors. So these inhibitors are able to prevent the repair of single-stranded breaks, which lead to an accumulation of the double-stranded breaks that can efficiently that cannot be repaired in these deficient cells, which ultimately cause cell death. Here, this is just stressing the importance of germline and somatic testing in most patients. So as we can see here, the NCCN guidelines, germline testing is recommended in almost all of our patients, whereas somatic testing is recommended in majority of our mCRPC patients and to consider in our metastatic CSPC patients. This was a study by Hussein et al. in 2020, which detailed the information on the responsiveness of mutations to PARP inhibitors in prostate cancer patients. The study focused on the efficacy of olaparib in men with metastatic CRPC who had disease progression during previous treatment. The overall survival was significantly longer with olaparib compared to our control therapy, which was either enza or abiraterone. Imaging-based progression-free survival was also significantly longer. So this study noted that the benefit of olaparib was less pronounced in patients with ATM mutations as compared to those with the BRCA1 and 2 mutations. And then briefly, as we've already discussed, PARP inhibitor toxicities, the main thing we think about is hematologic, mostly thinking about anemia. However, we also noted that thrombocytopenia, GI side effects, fatigue, all of these things exist. And a big thank you to Dr. Tawaji for her help. Thank you.
Any questions, any comments from our experts about the cases or anything you would like to emphasize?
Yeah, no, great job, Neha. So I think, one thing just kind of to mention, and I thought you did a really good job with this. The case you presented, the patient had an ATM mutation, and, obviously prostate cancer is later to the game in PARP inhibitors than colleagues in, breast or ovarian cancer. But we do know, yes, in general, ATM does not seem to respond. But this case itself, I think, illustrates when, there is a mutation there, there's some scientific thought behind a potential response when it's time that it is appropriate to still consider using the PARP inhibitor in that setting. Yes, you understand you might not see a response. That's not going to be unusual. But you should still, I think, in those cases, still be using that, until we have, better evidence to show that there's a better approach. I still think that's something to be used there.
Yeah, I agree. I think there's some data to suggest that homozygous ATM loss is potentially more susceptible to PARP inhibition than single copy loss. So Yeah, really interesting case. I think another thing to think about for that case is, was anything added by continuing the abiraterone or not? It seems to be progressing on it. Maybe there's some mechanistic synergy between ARSI intensification plus PARP inhibition. So, I think it makes sense. Sometimes if patients are on abiraterone and progressing and they have HRD, I'm switching over to Enza plus talazoparib. There's nothing to really say that that's the right thing to do. Beyond, it seems to, make sense. So I have seen it work anecdotally. So we need larger studies, and we'll gain that knowledge with time. But I think two great cases. I also have seen the pneumonitis a couple of times with EV Pembro, and it can be at first difficult to know what's going on. I had one time where the pattern was really consistent with metastatic disease progression, lymphadenopathy, multiple looked like lung nodules, more and some sort of reticular opacities. But did the full workup and biopsy, BAL, that stuff, and it was pneumonitis. So I think it needs to be on high on the differential when these patients come in.
Thank you.
Can I ask a question about the management of the first patient?
Yes.
It's always challenging when you have somebody with both an infection potentially and as well as pneumonitis. Is it wrong to consider just treating for both at the outset?
I don't think so. I mean, I think in this case in particular, when you look at the CT chest that they got in the emergency room, I think looking at that, some would say that that's enough evidence to be concerned for pneumonitis and to just kind of throw the kitchen sink, as they say, and do both. I don't think that's necessarily wrong. I think it was confusing because he seemed to be doing better with the antibiotics and then had progression of his hypoxia. So that's confusing. Yeah, interesting. You did it right. Thank you.
Any other questions? Okay, so we will have a break now, and we'll come back in about 40 minutes, I would say, to join the breast cancer session and the endometrial. And so, yeah, see you later.
They've been a little upgrade on the snacks upstairs, so you guys know. On my personal favorites, nuts, berries, and chocolate.
Hello, everybody. Thank you and welcome to the second part of our session today with the women's and GU cancers. So our first speaker is Dr. Vinod Solupiram. He's a Hem-Onc fellow at Cook County Soldier Hospital, and where they have great expertise in the management of GYN cancers. So they work with Dr. Gupta in this presentation, so we're very happy to have them here. So welcome, Dr. Vinod. We're
Hello. Good afternoon, everyone. Thanks for being here. I'm Vinod, as introduced. I'm one of the fellow in medical oncology. So today we're going to talk about ovarian cancer, and throughout the bulk of the talk is mostly directed towards epithelial ovarian cancers. And the way we're going to do it is we're going to give you the schema of how we treat the ovarian cancers and then post you updates from the recent meetings. So I don't have any conflicts of interest to disclose. Thank you. So just giving some outline on the talk, we will look at the trends in ovarian cancer. We'll look at a little bit on the history of the ovarian cancer, and we'll go by frontline, relapsed refractory setting, and talk about maintenance therapy as well. So from the recent database, we can see that ovarian cancer is the second most gynecological cancer in the United States. And it used to be the most lethal gynecological cancer, but as per the recent stats of 2024, it's second, and the first place is endometrial cancer. And an average of 1% lifetime risk for every woman in the United States as a risk of developing ovarian cancer. Worldwide, it's the third most common, and before it's endometrial and cervical. Even though it's not the most common gynecological, if you look at the mortality rate, it's pretty high from ovarian cancer. So here, I just wanted to ask audience a couple questions. Just take a guess. When was the first surgery for ovarian cancer removal was done? Just a guess. 1940? Okay. Anyone else? 3000 BC. Well, I think we are somewhere in the middle. So 1809, when Dr. McDowell did the first surgery, and this was the time when there was actually the concept of antibiotics, anesthesia, were not even there. So a lot of people who would have open abdomens for any reason were dying of peritonitis, but this surgeon managed to do it. He was a great surgeon, and that's when the first operation was done. And my second question to audience is, what was the first chemotherapy that was tried or attempted in ovarian cancer treatment? We have a lot of chemotherapies, so you can guess anything. That's a good try. It is the standard, but the first one tried was actually nitrogen mustard and its derivatives. So before 1950s, we were relying on just surgery and radiation. And in 1950s, after the World War II, some derivatives of nitrogen mustard were used with some response rates. And then it was later developed a little bit more, and melphalan was used, and which we use in myeloma now, but it was one of the first drugs to be used in ovarian cancer. And in 1970s, there were some reports that cisplatin can be used for ovarian cancer, and people started to look at more closely. And in the late 70s is when the concept of the debulking surgery came. And what they looked at is, at that time, debulking surgery, meaning trying to remove the tumor, and the residual tumor, if it is less than 1.5 centimeter, those people lived longer. Their 40-month survival was better. And now we do it differently. We're a little bit more strict on the debulking criteria. We want it less than 1 centimeter, but when it started, it was about 1.5 centimeters. And then later, cisplatin report came in late 1970s, showing that cisplatin can give up to 40% of complete response rates when used in the recurrent setting or second-line setting. And from there, once we established the role of cisplatin, drugs combinations were tried. We tried triplets. It was a little bit intense. Then we de-intensified to doublets. And we were searching for the best doublet. And when taxanes came in 1990s, they had a very good response rates with cisplatin and paclitaxel. But platinum has some toxicity to it, right? Especially like ototoxicity and renal toxicity and age and GFR and all those. So carboplatin was introduced, and it figured out that carboplatin is equally efficacious and less toxic. So from then, even to date, the carbotaxol remains the backbone for ovarian cancer. And then we've improved ourselves on using maintenance therapies with VEGF inhibitor, bevacizumab, and that is being used now as a standard maintenance in advanced ovarian cancers. And later in 2018, PARP inhibitors came into place, and followed by using PARP and bevacizumab as maintenance. And those were the times when neoadjuvant therapy was also being studied. The more recent development we have was mirvetuximab in 2023, using a very specific biomarker, FOLR1, in platinum-resistant space. And we're going to talk about some of these trials as we go through. So this is the treatment approach in ovarian cancer. So the first question still remains, is the patient a good surgical candidate up front? And if it is, then we do the debulking surgery. So looking back at debulking surgery, as I mentioned before, the goal is to get the residual disease less than 1 centimeter. And clearly, these people live longer compared to the ones who have a lot of residual disease, and has been proved multiple times. So our goal has to be that. Whether you do it in primary, or if you want to do neoadjuvant and do it after a few cycles, you can do it. The outcomes are okay, but the goal is to get the residual disease less. And if they're not upfront surgical candidate, then we use neoadjuvant therapy. And normally, a lot of studies tried, maybe 3 or 4, or some of the trials are even testing what will happen if we do more neoadjuvant chemos. But it turns out, with the evidence that we have so far, that is it really that good of doing a lot of neoadjuvant chemos? So a couple meta-analyses looked at this, and they were looking either less than or equal to 3 neoadjuvant or even more. And it looks like with every extra cycle that people get after 3, they don't do good. The survival decreases by 4 months. So this is important. The timing is important. So we should have a close watch with the gyn-onc surgeons, because if we are doing more and more neoadjuvants by delays or whatever, improper planning, we're not doing good to the patient. And there is currently a clinical trial enrolling, trying like 3 versus 6 cycles of neoadjuvant therapy, and we will see what the result. But so far, what we have the evidence is to do just our 2 or 3 neoadjuvant chemos. So a couple updates from ASCO 2024 is we've established the role of PARP inhibitors in maintenance therapy, but they've also been tried in the neoadjuvant setting. So the trial on the top, it looked at advanced stage ovarian cancer, and to the standard chemo and Bev, they added a PARP inhibitor called pamiparib, and patients can get up to 6 cycles, followed by surgery, followed by adjuvant chemo of choice. And unfortunately, in this population, there was no PAT-CR. Historically, even with carbotaxol, we do see some PAT-CRs, but in this trial, we didn't see it. And the second trial in the bottom also looked at using PARP inhibitors, but in combination with immunotherapy up to 6 weeks. And this trial was very specific to HRD positive ovarian cancer. And it looks like the PAT-CR rates are about 30%. The PFS is great, about 91% at 1 year mark. So this is something that is encouraging, and we will see more data because this is just a small phase 2 study. And when it expands, we'll see how it fares out. And there's a lot of other trials also going on looking at PARP inhibitors. And something that is normally done during a debulking surgery is retroperitoneal lymph node dissection. And there is some controversy of whether should all the patients receive retroperitoneal lymph node dissection. So there were a few trials, and this is one of them, that looked at if the patient had either pre-op or intra-op a normal-looking lymph node, they would randomize the patients to either get lymph node dissection or just omit the lymph node dissections. And it turns out when they looked at the outcomes, both PFS and OS in the intention to treat, they're the same. So this is something that we should consider based on the recent update. Not all of them get it, and it has significant morbidity. If it's not affecting the outcomes, then maybe we don't need it. And then we also talk about HIPEC when we do the surgeries. And HIPEC stands for heated intraperitoneal chemotherapy. And the idea being if you do a heated chemotherapy, it can penetrate into the tumor better. And because ovarian cancer has a lot of times peritoneal disease for effective circulation, they would do heated intraperitoneal chemo, usually with cisplatin, and circulate it for about 90 minutes or so. So this is a trial that initially came out in 2018. And neoadjuvant chemo by randomization to surgery plus HIPEC or just surgery, and then adjuvant chemo. And as you can look, the relapse-free survival and overall survival are better with HIPEC. But not a lot of people do it because the recent data at this trial, when it was published, we don't have good data to support, it's in the current era, meaning we use bevacizumab as a standard now. But when this trial was done, it was not used. So what is the role of HIPEC in current days era? And we know that bevacizumab, when we used as maintenance after standard chemo, in all comers, when it was analyzed in a couple trials, it didn't show any positive benefit. But when it was a subgroup analysis showing that there are a certain group of patients who do benefit from bevacizumab. So who are these patients? They are the patients who are like either stage 4, or they have ascites, or they have like a suboptimal cytoreduction. These patients tend to do better, and they have a better PFS and OS with bevacizumab. And with the current day maintenance therapies, which includes Bev and PARP inhibitor, there is a trial. The schema was presented at ASCO that is enrolling patients with advanced ovarian cancer, and they would do randomize at the time of surgery to HIPEC or control, and then they would go for maintenance. So this would act as the HIPEC in today's world. So we'll see in the next few years what it turns out. So next, once we are done with the surgery, we talk about adjuvant chemo. So in general, when doing adjuvant chemo, there are two options, right? So one is just to do conventional IV chemotherapy, or to do a mix of IV and intraperitoneal chemotherapy. And if you have a lot of tumor left, meaning suboptimal reduction, there is no role of intraperitoneal chemotherapy because physiologically it doesn't penetrate that well, a lot of tumor there. So the only time we talk about intraperitoneal is somebody who has an optimal surgical debulking. And this is a trial that looked at thing. So about 400 plus patients were randomized to like either just conventional IV chemotherapy, which included platinum and Taxol, or they would also do like intraperitoneal chemotherapy. And it turns out that intraperitoneal chemotherapy is better in both PFS and OS. But only 40% of the patients were able to complete this. Because intraperitoneal chemotherapy is not the easiest thing to do. We want it to circulate. There is a lot of manual work in moving the patients. It has more hematological toxicity, more toxicity, and morbidity as well. But again, this trial was also done at the era where bevacizumab was not a standard. There were several other meta-analyses that showed that there is benefit of intraperitoneal, but as I said, none of them considered or were done during the time. Trial GOG-252 was questions. What is the role of intraperitoneal chemotherapy during bevacizumab? So they randomized it into 3 arms, and you would get one of chemotherapy, and the intraperitoneal could be variable type of the agent. And maintenance bevacizumab for 15 months or 22 cycles, which is what we do normally. And their outcome seems to be similar. So chemo did not add much when maintenance. So in our institutions, we normally don't do it, but I think it's an option for somebody. If they cannot get bevacizumab, that's something that they can try. And the standard IV, what we do is conventionally we do every 3 weeks, carbo and carboplatin and paclitaxel. There are some other options like dose-dense strategies. And bottom line summary of all the trials is people showed that it is kind of same in efficacy when but if you have a frail patient who cannot get the Q3-week dosing because of side effects and all, you can use weekly dosing of either carboplatin and paclitaxel, and the efficacy outcomes are the same. Now, there was a recent study and then an ESMO update on immunotherapy along with PARP inhibitors in the adjuvant settings. So this was a study that was presented at ESMO, 3-arm study. Arm 1 is the standard, which is chemotherapy maintenance. In Arm 2, they would add durva. In Arm 3, they would add olaparib maintenance to the durva. And when we look between Arm 1 and 2, there was no big difference. I mean, not maybe a difference. But Arm 3 was much better compared to the both. So the question here is, did the durvalumab add anything, or is it just olaparib that is making the difference? So this was, we'll see more data when it comes out, but so far the immunotherapy in ovarian cancer has been very encouraging. But when we look at Arm compared to Arm 1, yes, it is better. And about maintenance therapy, we talked about a couple trials that used Bev as the maintenance therapy, and we use it in advanced ovarian cancer as a standard, but we also have PARP inhibitors available now. And thankfully, a lot of speakers before me talked about PARP inhibitors. Easy. And again, going back to the mechanism, it is important how it works. Any damaged cell, when it has a double-stranded DNA break, it depends on 2 things. One is homologous recombination, which is a much better, efficient, and less prone for errors. And the other one is non-homologous end-joining. Also does the double-stranded repair, but there can be errors, mutations, which can lead to cell death. And PARP inhibitors are normally used in the repair of the single-stranded breaks. When homologous recombination mechanism is deficient for any reason, then the cell depends on PARP inhibitors and homologous end-joining. And if we are able to block that with using the drugs that we have, we are inducing synthetic lethality in the cell, and that's how the cell is going to respond. So when we want to know or the cancer is HRD, what do we mean by that? So there is a score of things like loss of heterozygosity, allelic imbalance, and transitions. And they came up with an algorithm, and this was used in some of the clinical trials with a genomic instability score. So usually if it's more than 42 in the trial, it's considered a positive HRD or HR deficient. And in ovarian cancer, it turns out like more than 40% of the tumors can be HRD positive, deficient. So this population is where the PARP inhibitors are going to give you good benefit. Something interesting was presented at ASCO 2024 is using AI in analyzing this. And they would train the AI model to look at the slides, the pathology slides, and try to predict their HRD status. And it was validated in a small number of patients, and it did turn out to be a positive one. It was encouraging, like there was a 75% correlation or something like that. And it's being validated in a bigger trial now, so we'll see. It's something exciting coming. This will save a lot of time and also money. So the first trial that looked at PARP inhibitor maintenance was SOLO-1, and this trial included patients exclusively BRCA1 and 2, and they randomized after you have response to platinum, which is either PR or CR, patients would get either olaparib or placebo. And a 7-year follow-up, the median overall survival was still not reached in these patients who got the PARP inhibitors. When they designed the trial, the protocol was designed in a way that their value of significance was very, very stringent. Like it has to be less than 0.0001. And even though we could see from the curves that there is a big difference, it was, by trial standard, it was a negative. It was not statistically significant. But we know that we can look at the benefit there. And something that comes up with PARP inhibitors is the risk of MDS AML. So when PARP inhibitors were first studied in like the recurrent settings or later lines, these patients already got a lot of chemo. So they had much higher incidence of MDS AML. But when we are using now in the frontline setting as a maintenance, we don't see as much MDS AML. It's still there, it's a little bit higher than placebo, but most physicians would agree the benefit is more than the risk of MDS AML. And SOLO-1 is the trial that looked at combining PARP inhibitors with bevacizumab. So this was an all-comer population with advanced ovarian cancer that randomized patients to olaparib bev, bev alone. And as you can see, even in all comers, it was significant, but majority of the benefit was driven from the HRD population. So HRD positive, including BRCA, HRD positive non-BRCA, it was an FDA approval to use in HRD positive patients. It was a 5-year follow-up that came up, and looking on the left, you have HRD. You can see clearly there is benefit. BRCA1, 2, clearly benefit. In HRD positive non-BRCA, the sample size becomes small when you do subgroup analysis. So we don't always get like the right conclusion. But you can see there is some like modest benefit. It was not significant, but there was some benefit. In HRD negative expected, there was no benefit. And PRIMA trial that looked at a second PARP inhibitor called niraparib, which we do is like 300 once a day tablet, and same type of population, advanced ovarian cancer, all comers, and they got randomized to niraparib or placebo. And as you can see on the top, the PFS for HRD deficient patients or HRD positive was great. Even in the all comers overall population, the bottom graph, it was still positive. So this one carries an approval to use it in all comers. And when we use niraparib, we use it for 3 years. For olaparib, we use for 2 years. And in 2024, an update came on this trial at 3.5-year follow-up. As you can see, the survival analysis on the left, there was no benefit in overall population. And even when they analyzed specific to HRD positive, so that patient population also did not have an overall survival benefit. There was a PFS benefit, but there was no overall survival benefit. So it is kind of falling out of favor, but it still carries label approved indication. And there were some analysis on using niraparib, and as we know, as we proved in the trial before, there was a PFS benefit favoring niraparib in both HRD and positive and negative. Now let's talk about relapse refractory. Eventually, a lot of ovarian cancers will relapse. And when we talk about relapse, we talk about whether they're platinum sensitive or platinum resistant or refractory. And the definition has been that 6-month mark. So if somebody recurs within the 6 months of stopping platinum, we call them resistant. If they're progressing while getting platinum, they're refractory. But if the recurrence happens after 6 months, then it's a platinum sensitive recurrence. And usually when it recurs, we of course get the staging and restage and everything. But if we can do a secondary cytoreductive surgery, that can be an option, and we'll talk about that. But if they cannot go for surgery again, and if they're platinum sensitive, we tend to use platinum. And even in our experience, they tend to respond good to platinum. The only problem, though, the more and more platinum that you give, people will tend to react to it. So that becomes a problem in the future. But if they're platinum-sensitive recurrence, it's better to use a platinum drug in combination. You could use the same induction that you used before or a different combination that has a platinum backbone. In the resistant and refractory is where people do badly. This space actually had no good treatment for a time. Recently with NGS and all, we are able to detect some good biomarkers and have some targeted therapies for it. So this space, it's recommended to have NGS because we can look for these markers, FOLR1, mutational burden, HER2, and NTRK. NTRK is less common, but we should look for it. If they don't have any of those, then unfortunately we have to go for chemo when we use like single agent or even double agent. But the historically responses to chemo are not that great in this setting. So as I mentioned, secondary cytoreductive surgery. So this was studied in few trials, and the one that I'm showing now is in 2019 in platinum-sensitive recurrence. So when they randomize patients to do secondary cytoreduction plus chemotherapy or just chemotherapy, we can see as an overall intention to treat, there was no benefit. It was not significant. But when they analyzed patients who got complete resection of the disease, there is significant PFS and overall survival benefit. And another trial kind of replicated the same outcome in patients with platinum-sensitive recurrence. And this study almost had like 75% of them were able to achieve complete resection by surgery. And as expected, like the previous trial, the PFS and overall survival were statistically significant. In 2024 ASCO, an update was presented on this trial, SOC1, which looked at the same thing, cytoreductive surgery or no surgery, and just give standard chemotherapy. This trial was a negative trial, and it was not a full paper, but in the abstract, the authors mentioned that about 35 to 36% of the patients crossed over, and that's why they didn't see the benefit. And they did an analysis at just crossover, and then it turned out to be a significant benefit for doing surgery. So the goal is if you can get gross resection completely less than 1, is something that can be considered carefully in some patients. And if you're considering secondary cytoreductive surgery, there is a trial that was presented. It's currently enrolling. The schema was presented. While doing the secondary cytoreductive surgery, is there any role of HIPEC? So this, we will see what it turns out to be. But this is something to see, like, if HIPEC has any role in the recurrence setting. Now, the NEO trial in platinum-sensitive recurrence was to look at PARP. So they would get PARP inhibitors for about 6 weeks and then go to surgery, and after that, either chemotherapy or just continue maintenance olaparib. And the outcomes, this is a small study. I mean, it was like less than like 30, 40 patients, something like that. And overall survival benefit turned out to be the same. There was no difference between the groups. And the update that was studying olaparib in a recurrent setting. So these are the patients who actually had a relapse and they were put on olaparib. And it seems like, and this study, the olaparib was continued until disease progression or death, not like the 2-year mark that we do in the front line. And people seems to be responding well, especially the BRCA mutant and the HRD positive patients. And this trial had a follow-up of almost close to 10 years, and the incidence of MDS AML was 1.3%, which was encouraging. And in platinum sensitive, a chemo-free approach was also tried. This study, about 20 patients was presented. with pembro and lenvatinib, which we commonly use like in endometrial and renal cell malignancies. So people would get up to 2 years of immunotherapy and lenvatinib, and it seems like the response rates were upwards of 50%. So in somebody who can not get chemo for any reason, or their comorbidities or anything like that, this is something that turns out to be an attractive action. Although we have to wait like the full data and like a bigger trial to confirm the efficacy, but this was encouraging. But the biggest update in the last few years in the platinum-resistant setting was mirvetuximab in the MIRASOL study. So this space was a very bad one where there was no agent that was improving survival. But in this trial, the platinum-resistant disease, patients were randomized to mirvetuximab, which is an antibody-drug conjugate, or investigator choice chemotherapy, and they analyzed the outcomes of both PFS and OS. So mirvetuximab was given to patients who had FOLR1 positivity, meaning this is a marker that was tested on IHC. Usually FOLR1 happens about maybe 40% of the tumors in the ovarian cancer in platinum-resistant setting. And if they have that, they have to have an IHC 2+ in at least 75% of the tumor cells. That's considered positive. So those patients were randomized to mirvetuximab or chemo. And it turns out that the PFS and overall survival was better with mirvetuximab. So this remains the only agent so far in platinum-resistant space which has a survival benefit. It has some unique toxicity to it, especially like the ocular and neuropathy. And it is recommended that, with every alternate cycle to see an ophthalmologist. And also we do prophylactic glucocorticoid drops as well. And is it safe in older patients? So post-hoc analysis of the MIRASOL study was presented, and that looked at patients more than 65 years. It was about 200 patients, and the efficacy is there. It's still significant in survival, and the toxicity profile was also similar. So older patients can also tolerate. And if 66% of the people were alive at 2-year mark, that's a great thing in this state. And atezolizumab was also studied in platinum-resistant disease. And usually, as I said before, immunotherapy has not been very exciting in ovarian cancer. And this was a platinum-resistant disease patients with either atezo or placebo. They can get BEV, which we normally do in the platinum-resistant. And this turns out that it was a negative study. But there was one encouraging positive thing from ASCO, which is using a different type of VEGF targeting. So this trial was done in Asia, where people with platinum-resistant disease would randomize to suvemcitabine, which is a novel VEGF inhibitor, or they would get chemotherapy or chemotherapy plus this agent. And when they looked at the PFS and overall survival, the PFS was statistically significant. But the overall survival, at the time of analysis, the data was not mature, so it did not show significance. But we will have to wait and see what it comes out after a few months. And there was another study that looked at using TDXT, which is a different ADC targeting HER2, and we use it in like several other cancers already. This was a Destiny Pan-Tumor 2 study that looked at 7 different types of cancers who had no alternative good treatment, and then enrolled them to get TDXT. So TDXT turned out that if you have IHC 3+, it had a response rate of more than 60%, and if you have 2+, more than 36%. So this is something that can be used in patients who have resistant disease or who have no good alternative, and if they have 2+ or 3+ on the HER2. So that's why it's important to do keep this in mind, and if the patients are progressing, send these for testing, and they may get good responses from it. Some other clinical trials that are being presented, they are still in the enrolling phase. So this is REJOICE, which is trying to target CDH6 or cadherin-6, which can happen in about 60% of the patients in ovarian cancer. And using the antibody drug conjugate targeting this. So it is still enrolling, so we will have to see what it turns out to be. One of the less common histology, not the high-grade serous, but there is a clear cell carcinoma in the ovary as well. So this Brooks study looked at using dual immune checkpoint inhibitors like ipi-nivo versus just nivo. And this study included non-renal clear cell carcinoma, but about 80% of that study population was ovarian. And it turns out that the PFS and OS seem to be much better if you use dual immune checkpoint inhibitors. But this is a small study, so we have to wait if it's going to do a phase 3 and see what the results will be like. But this is something encouraging in this group. So summary, optimal debulking still remains the cornerstone, and it's the goal to get less than 1 centimeters of residual disease. And we use BEV plus minus PARP inhibitors if they're eligible for maintenance treatment. If you use olaparib, it's for 2 years. If you use niraparib, it's usually for 3 years. And there is a role of secondary cytoreduction in certain carefully selected patients during recurrence. And if a platinum resistant disease comes up, then the standard of care is mirvetuximab right now. And always one thing is, during any disease progression, it's a very good idea to do NGS and look for some other biomarkers that we looked at, so we can target them essentially and get a good responses. With that, I will end it. Thank you, everyone. Yeah, if you have MSI high or DMMR, there is a blanket approval where you can use immunotherapy, and there are some responses that you can see. There is no trial specifically enrolling for just MSI high, but in general, when we look at all solid tumors, if you have a tumor mutational burden more than 10 or MSI high, they have better responses to immunotherapy. So that is something that is approved, and we can use it. They don't have other options.
Questions?
Yes, would you highlight about Paola's study the importance of bevacizumab up front? As you're planning to do maintenance therapy, which now everyone with ovarian cancer, fallopian tube cancer, primary peritoneal should have maintenance, it's very important. We have to remark that patients must have upfront bevacizumab. To start the bevacizumab at the time of maintenance, for whatever reason, we don't really understand the mechanism, it doesn't really work. So I just want to remark that aspect. And that's how the Paola study was conducted.
Thank you. I haven't seen anything published yet so far, and I think there are people studying it. It is coming out in some other solid tumors, but nothing in ovarian so far.
Thank you, Dr. Vinod. Our next speaker is Dr. Abiola Ibrahim. She's our breast cancer expert at USC. She's assistant professor, and she will talk about new updates in endocrine positive breast cancer.
So I'm standing between Ursula and Dina. So I have nothing to disclose. This is just going to be an update of everything that has been going on in the last couple of few months. Okay. All right. So this is pretty much the outline. This is a multidisciplinary discussion where we'll talk about some radiation surgery and some targeted therapies and some systemic therapies. So pretty much, I will try to tell a story and put us in the clinic or probably in the MDT or tumor boards where we have discussions about this patient. So the question is, when a patient comes in with DCIS, what do we do for this patient? So we think that active monitoring may be as good as surgery for low-risk DCIS patients. So why do we think so? So in the most recent San Antonio breast that concluded about a month ago, the comment study was actually discussed. And the comment study really is a prospective randomized non-inferiority trial. And what they did was they looked at patients that had low-risk DCIs. So what is the definition of low-risk DCIs? So low-risk DCIS is defined as a patient that has a grade 1 or 2 hormone receptor positive DCIs at biopsy. And the DCIs seen on imaging study could be greater than 4 centimeter. And when it's greater than 4 centimeter, you must have done multiple biopsies for you to actually say that this patient most likely has DCIs. So why is this important? This is important. This question was important because for most of our patients, we classify DCIS as it's not cancer, it's precancerous. Then the patient tells you, okay, if this is not cancer, why are you cutting it out? Why are you putting me through radiation? Why are you doing hormonal therapy? So this is the reason. Okay, so for us to answer that question, can you hear me? I feel like I go in and out. All right. So for us to answer that question now, I really love this study. Now I feel like I can just pull up this study and we have a discussion with the patient. So the participants of this study were greater than 40 years old, and they had a new diagnosis of DCIS. There was no invasive cancer, and they've never had cancer in the past. So they were randomized 1-to-1, and some people were randomized to get the guideline known, which is they got the usual care, which is surgery or diagnosis. They could get breast conservative surgery, which is or mastectomy, and then they got radiation as per the rad oncologist, and then they received adjuvant hormonal therapy. Then the other group were just the active monitoring group. So those people were getting ipsilateral mammogram or MRI every 6 months. And if there's any change seen, they got a biopsy and then they continued to get monitored. Now, if the patient decided that they wanted to move, they wanted to get any intervention, they were free to cross and they could get adjuvant hormonal therapy as they wished. So the primary outcome was this. The primary outcome was they wanted to see if there was any invasive breast cancer at time of surgery, and we wanted to see if there was any changes at monitoring for the active monitoring group. So what we did see, again, is that over almost 1,000 patients were enrolled, half and half, and they were about the same group, and they followed this patient over 2 years. So the summary of this is that at 2 years, what we did see, again, remember it's low-risk DCIS. At 2 years, what we did see is that the ipsilateral invasive cancer was 5.9 versus in the arm that we were actually actively treating versus 4.2% in the patients that received active monitoring. Now, 31% of patients did not adhere to their arms, meaning that more patients favored active monitoring. So some of them crossed over because they just wanted to be monitored. So what this is telling us is that active monitoring is not inferior to the standard of care that we have. So in summary, if you do have a patient that has DCIS and they just want to be monitored, it is okay for us to just continue to watch them every 6 months. And if they want to get hormonal therapy in addition, that is fine. We just continue to monitor with mammogram, with MRI, depending on what insurance that they have, and we'll go from there. All right. So any questions on that? So we already answered DCIS. Next stuff. What about the use of hormone therapy in DCIS? Okay, that's another question. I see a patient, DCIS, done everything, and then I say, well, you're going to be using hormonal therapy for 5 years or 10 years, and they tell me, wait a minute, you just told me it's not cancer. Why am I getting hormonal therapy for 5 years? Okay, now we have the reason. Okay, so the thing is, the impact of hormonal therapy is less established in these patients that have DCIS. The NSABP 24 did not actually show anything as far as tamoxifen in this group of patients. So what have we been doing in practice? It's a joint discussion between the physician and the patient, and we'll go from there. So the next point is, the question is endocrine therapy beneficial in DCIS? So what they did in, again, the last San Antonio is that they looked at those studies. This studies has been ongoing, the NRG RTOG 9804 and the EGOG Agrin E5194 studies has been old. It's ongoing over 15 years, and all they just did was to say, okay, what is the update? So this group, the first one actually randomized and enrolled good risk DCIS. I mean, sometimes not all DCIS are equal, right? Again, we keep talking about good risk, low risk DCIS. And the good risk DCIS, according to the RTOG study, was DCIS with sizes less than 2.5 centimeters, grade 1 to 2, and they had great margins or negative margins. And those patients received radiation therapy versus the EGOG trial, which enrolled 2 prospective observational cohorts without radiation therapy, and also they had good risk characteristics. So in both trials, the use of tamoxifen was optional, but then it was tracked. So the patient characteristics again is that we see that most of the patients were older than 50 years old. They were mostly postmenopausal patients. So they had negative margins. The size of the tumor for the most part was actually equal on both arms. In the tamoxifen, yes, or tamoxifen, no arms. And then they were grade DCIS grade 1 and 2. So what this actually showed, what they reported in San Antonio was this. They showed that tamoxifen shows a significant reduction in overall recurrence in this group of patients. So the question of us using endocrine therapy in this group of patients has been answered. So, I mean, instead of us going back and forth, like, I really don't know, what do you think, and all that stuff, we actually do have the data here. And it's shown that after 15 years of following this patient, the ipsilateral breast recurrence significantly reduced among patients who received tamoxifen for DCIS. So, what about women older than 70 years old, old patients, right? So the question about how do we treat this patient? The standard of care for this patient is they get surgery, whether mastectomy or breast conservative surgery. They get radiation therapy, and they do get endocrine therapy afterwards. So the ACCREDITED study, which is the exclusive endocrine therapy in women aged 70 plus years with luminal-like early stage breast cancer, which is stage 1, they wanted to see if we can actually reduce treatment burden and balance treatment efficacy. And this was, or to measure this, we're going to be looking at the quality of life in these patients. And the reason for this ACCREDITED study, again, was because we've had older studies whereby we omitted radiation therapy for older women. And when we omitted radiation therapy for older women, we were seeing that they had increased local recurrence. Now, we say, I don't know why they even put the age for 70. Like, 70 is an arbitrary age. I think way back then, when you hear 40, they were like old people, but now 40 is the new 20, and 70 is going to be the new 50. So I think we have to really start figuring out what the age is. I digress. Right. So the life expectancy for women generally in the United States is about 85, 86. So the older studies that omitted radiation therapy, these women lived longer to actually have increased local recurrence. So now, and we also know that as women get older or patients get older, they are more likely to have comorbidities, be using all their medications, and they certainly would not really be compliant with the endocrine therapy for 5 years or 10 years or what have you. So the IFERIA study was necessary. So what did they do? This is the outline of the study. It was a phase 3 trial. They enrolled about 926 patients. And it was an early stage hormone receptor positive disease. And they randomized patients one-to-one to either receive radiation therapy or to receive endocrine therapy, and they followed them up. So as far as the radiation therapy was concerned, the people that received the radiation therapy they received the whole breast radiation and different fractions, and it was just for them to be able to tolerate the radiation therapy that they were getting versus patients that received hormonal therapy for 5 to 10 years. So they looked at what we call the global health status to see, and this is just the most recent, this is a 2-year overlook of the study. And what they saw is that this patient, the global health status, just indicates overall health status of the patient. And they saw that the patient that got the radiation arm actually felt much more better. And they did well better overall than the patients that were getting hormonal therapy. And knowing what we know from our older studies, we do know that patients that just got radiation therapy, probably without hormonal therapy or with some hormonal therapy, would not have local recurrence, right? It's still an early study. It's like 24 months old, and we will see. So we will be staying tuned on that. So pretty much, the IFERIA trial, a summary of this, shows that health-related quality of life was improved in patients that received radiation therapy versus patients that received endocrine therapy for stage 1 luminal, which is most likely luminal A breast cancer. And we also see that patients had less side effects when they received the radiation therapy versus endocrine therapy. So pretty much it's just how do we treat our stage 1 elderly patients. And I think that we're in the era of less is more, right? For our patients, we're in the era of the quality of life really does matter. So we are moving on to neoadjuvant therapy. So when we talk about neoadjuvant, part of the things we want to think about when we start saying are we going to treat this patient before surgery is we want to look at the tumor biology. For HER2 positive disease, large tumor size, triple negative disease, most likely we are going to do, most people are going to do neoadjuvant therapy. For hormone receptor positive disease, unless the patient has some feature like that is concerning, like they have high risk 2 on mamma print, or they are looking like more like a triple negative picture, I really don't push for neoadjuvant therapy. And the goal of treatment is a PCR or tumor response. So again, San Antonio, we talked about neoadjuvant treatment using antibody drug conjugate. So this study was actually conducted in China, and they looked at HER2-directed antibody drug conjugate called the SHRA1811 in neoadjuvant treatment of HER2 positive breast cancer, and it was a phase 2 study. So now this study is very unique in as much as they enrolled all comers, but I'm just going to be talking about the HER2 positive subtype group that was enrolled in that study. So the patient had to be 18 years or older. It was large tumor size. The T was at least greater than 2 centimeters. And it was early stage disease. It can be metastatic breast cancer. And they used IHC 3+ or FISH amplified to make sure these patients were eligible. And then as far as hormone receptor positive status, if the patient had hormone receptor positive, they were able to enroll this, they enrolled this patient. And then they were randomized this patient to receive the study drug. The study drug, SHRA1811, an antibody drug conjugate, and that was one arm. And then the second arm was the study drug and pyrotinib. Pyrotinib is like neratinib. I don't know, do we have that in the United States? Okay, okay. All right. So it's like the brother to neratinib, in fact, that kind of a thing. So, and then standard chemotherapy, which is the dual anti-HER2 treatments that we always give our patients as neoadjuvant standard of care. And then they had surgery, and then the primary endpoint was PCR, pathological complete response. Okay, so like I just said, it's like neratinib, that's what it is. Okay, so results. So this is a very interesting study because, you know, sometimes you think that when you do so more, you should see a better PCR. The highlight of all this is that there was no significant difference in the PCR rate among the study drug, which is the SHR A1811, or even the second one when you added the pyrotinib, or when you do the standard of care dual anti-HER2 therapy. So for this group of people, the PCR was the same. So when you look at or even compare the hormone receptor negative versus hormone receptor positive group, again, the PCR was about the same. So the conclusion was, of course, this is the first study of our antibody drug conjugate in the neoadjuvant era for HER2 positive disease. But we see that the PCR was the same even with our chemotherapy that we use. The four drug conjugate combination was not effective and it had a lot of side effects. However, what we could see from this study is that when you compare this anti-drug conjugate, the side effects with our dual chemotherapy backbone dual HER2 treatment, the side effect profile was much better. And maybe, just maybe, at some point, we can do away with chemotherapy in neoadjuvant treatment. So this is why this is exciting to us. So the next question right now is, what about neoadjuvant HER3-DXd alone or in combination with letrozole for hormone receptor positive HER2 negative early stage breast cancer? This is the Valentine trial. Again, this was conducted in Spain. So 120 patients were enrolled on this study. The pre-post menopausal patients. These were patients that had a tumor size. It wasn't really that big. It was less than 1 centimeter. They had hormone receptor positive disease. The Ki-67 was greater than 20%, and there was, of course, no prior history of breast cancer. So they enrolled these patients 2 to 1, randomized by 2 to 1 to the study drug versus the study drug with letrozole and standard of care doxorubicin anthracycline-based chemotherapy, and then they did surgery, and the primary endpoint was PCR. Now, a little fun fact about hormone receptor positive breast cancer: unless you know that it's going to be acting like triple negative breast cancer, neoadjuvant treatment just doesn't work, right? It doesn't work. The best response as far as PCR is 5%. Even 5%, we are pushing it. So it did not disappoint, right? So before, this was the baseline characteristics. They had, like I said, the tumor size was equal across the board. The Ki-67 also was high. So there was a thought process that it should actually respond to neoadjuvant treatment. So this is the PCR. So the chemotherapy part actually was worse, 4.2%. I used to think it was 5%. Okay, 4.2%. But even though the study agent, HER3-DX, was about 4%. It wasn't different from chemotherapy. And funnily, when you add letrozole, it's even worse, 2.1%. So what that has told us is that, again, do not do neoadjuvant treatment in hormone receptor positive breast cancer. However, if you must do neoadjuvant treatment for whatever reason, maybe a huge mass or you think that maybe this might work, this has shown us that this antibody drug conjugate might be better than chemotherapy with respect to toxicity profile. So for the same 5% that I'm getting, I think I'll go with them, right? Because then they have less side effects and the quality of life of the patient is much, much, much better. All right. So we are going to be moving on to triple negative breast cancer. Am I still on time? Am I on time? So triple negative breast cancer, again, when we talk about how the strategy of treating this patient, we want to, the good news is in this group of patient, immunotherapy, we want to see the CPS score that's going to help us determine if we're going to be doing chemotherapy in this patient, BRCA mutation or the BRCA-ness. Of course, in all kind of cancers, the previous one, the BRCA mutation is important, especially if the patient has some genetic risk for that. So this is not new. We talked about this the previous times. Everybody knows this study, our keynote 522 that made immunotherapy the reason why we use it in neoadjuvant treatment. And then we see that also the addition of immunotherapy in this group as neoadjuvant actually is much, much better than just chemotherapy on its own. So what is the update of this study? So the updated data from the 522 study shows that we don't need to go by CPS score alone. There are other biomarkers that's going to indicate that the patient might tolerate or might respond to immunotherapy. So in addition to you looking at the CPS score, we see that the T cell inflamed 18 gene expression profile express improvement in PCR and event-free survival. And additionally, we think that patients that have high tumor mutational burden also are more likely to respond to this treatment. So in addition to the CPS, we have other things that we can look out for. So the Olympia trial, again, this is the schema. I spoke about this the last time. We all know this is it's like relatively oldish. When I say oldish, I think 2 years and it's old now. So now we are talking about everything is new, right? So what is the update of the Olympia trial? So the update of this is that even with all this extensive follow-up, we see that the addition of PARP inhibitor to someone that has a germline BRCA mutation, it continues to show improvement. And then we see that it's consistent across all the groups. And the concern about the use of PARP inhibitor has always been MDS or AML in these patients. And we shouldn't be concerned because we have not even seen the side effects of this, causing us some concern. And the final follow-up is going to be 2029. We'll look up to that. We are looking forward to that. So what about the adjuvant part of it? Now I'm on the adjuvant part of hormone receptor positive. We know that the monarchy, the Nutella trial makes you decide to use abemaciclib versus ribociclib in the adjuvant setting. What do you want to use? When you look at the two studies and you put them side by side, you can look at that and decide which one of them or what actually works for you. I won't mention what I use, but I use the one that likes to cause diarrhea and probably make people lose 10 pounds. Again, if you don't want to do that, I can let you have neutropenia depending on what. I'm not mentioning any names. But then when we look at that, we can decide on our patient choice. All right, so this has been approved. So now let's move to the metastatic breast cancer update. We do know that now it's been over like 10 years now that we've been using CDK4/6 in this group. So there's always a which is better. We don't know this because there's not been comparison. However, we did a real world study. The P45 study was also reported in San Antonio, and we did see that there was no OS, none is better. They're about the same. So right now, your choice of CDK4/6 in this group of patients is a discussion with your patient, maybe your system, maybe the healthcare system, and toxicity profile. All right, so this we showed last, my colleague showed this slide last year, so she was kind enough to share this. So again, this is just the outline of how do we make our choices and the studies that actually inform us on this level of first line treatment, second line treatment, and what have you, depending on what that we pick. Am I still on time? 10 minutes? Oh, okay. All right. So that has been updated from the last time we talked about this. The new update is that, yeah, we want to add one more thing to it, right? That's why not, right? In addition of this, and of pick 3-ICK as first line, not only in advanced and locally advanced disease, we see that there's a huge advantage to adding that, right? But what is the trade-off? Hyperglycemia. This can be managed in the clinic or managed up front. All right, so we will be powering through right now. And then, so again, this is hormone receptor positive with patients that have visceral crisis. Now, from what I've said in the previous slide, there will be a time whereby systemic chemotherapy will be irrelevant in hormone receptor positive patients, especially since we are beginning to show that it's about the same response with our antibody drug conjugate with less toxicity profile. All right, so the Destiny 06 was updated again in San Antonio. And one of the things they were able to show was that it's less toxic and for the benefits. And this is one of the reasons why being an oncologist in the research field is very, very, it's a privilege for us to do that. So now we talked about the EMBER-3 trial was also presented at San Antonio Breast. And then, I mean, we talked about this selective estrogen receptor degrader as either a monotherapy or combined with a CDK4/6 inhibitor in a patient with advanced breast cancer. And so I'm not going to, I'm almost running through my time, so I'm just going to run through a lot of things. So this was the rationale with which they used this, and they felt that the addition of the SED with the CDK4/6 inhibitor was actually going to cause much more PFS. So the design of the study really was patients that record after using CDK4/6 was allowed to be on this study, and they were randomized 1:1 by using the SED or standard of care, depending on fulvestrant or exemestane, or the third group is the SED or the CDK4/6 inhibitor. And the primary endpoint was PFS. All right, so looking at the adverse effect of this, we did see that the adverse effect of this was actually tolerable. So now looking at the SED with the standard of care fulvestrant or exemestane, we saw that imlunestrant actually did better on its own. And then when you combine it with abemaciclib, comparing it by side to side, also it's much, much, much better. So now it's all about toxicity profile at this point. So the conclusion really is that imlunestrant monotherapy significantly improved PFS. Now, when you add it with CDK4/6 inhibitor itself, the PFS is much, much more improved regardless of the ESR mutation status. Now, so depending on your ESR mutation status, if you have, so the summary of this, you have ESR mutation status, you can, if the cancer is ESR1 mutated, then you can actually use this as a monotherapy, and if it's not, you can just add abemaciclib with it. So now we are getting into murky waters because now we are getting a lot of all these orally available said drugs. We now have a lot of choice to make. And how do we decide on what to use? Initially, there was a time it was just tamoxifen, arimidex, and what have you. Now we have a lot of things, right? And even on the said group, it was more of just fulvestrant, and it's IM, very painful. Now we have a lot of things that we can use going down the list. And the question now again is the toxicity profile, which you can actually choose from depending on, when you're combining the treatments together. So these are the studies that actually got this treatment approved. I just talked about the EMBER-3 trial. I'm not going to be talking about the rest of this trial, but we already have that here. It's about the same thing. So what is upcoming? So the upcoming, or the ongoing really rather, is that we have the EMBER-4 trial ongoing. In the ongoing adjuvant treatment, which is between 2 to 5 years of standard endocrine therapy, we have the EMBER-4 ongoing, Elegant is ongoing, Canberra is ongoing, and we should be getting results probably 25 or 20, I don't know. I'm just saying, putting it out there. And then also, as we have the Canberra and the IDERA trial ongoing to tell us, the use of SED as an initial therapy. So, how do we put all these things together? Now, we're at the point whereby, as adjuvant endocrine therapy, it used to be tamoxifen and AI depending. But now things are going to change, whereby at some point, after these whole studies, we will have a lot of things to choose from, and hopefully they would have less side effect profile. And then genomics is going to matter. Whether the patient has ESR1 mutation or they have PIK3 kinase, whichever way, then that's going to help us decide what treatments we are going to choose. So what that means is that we have more options, again, genomics, and we can move on to second line and third line and beyond. So this is a triple negative REM, whereby right now on the triple negative part, apart from immunotherapy, now we are having a lot of combination antibody drug conjugates in this group of places. So the metastatic triple negative breast cancer, we are going beyond chemotherapy. By the time you're using chemotherapy in metastatic triple negative breast cancer, you must have gone through a lot of targeted therapies with less side effects. So the last study I'll be talking about is the triple positive breast cancer that also was discussed. That is the PATNA trial, which looked at the use of anti-HER2 therapy with palbociclib, and we looked at that study. And the rationale for that study is that HER2 and CD4/6 pathways converge at the tumor suppressor proteins. So if we actually combined this treatment, the question was, can we actually have a more longer PFS? So the patients that were enrolled on this study, again, were patients that has never received any treatment in that. It's like first-line treatment, and these were triple positive breast cancer patients. So they received 6 cycles of dual anti-HER2 therapy in addition to palbociclib, and then they were randomized to palbociclib and that anti-HER2 therapy. And then they were followed over time till disease progression. So part of the things that we learned in San Antonio was, of course, it was going to be a positive trial. I don't even know why we didn't think it was not going to be a positive trial, right? So, and right now, we see that we have a confirmed overall, what is this? Let me see. So, of course, we have a positive PFS 44.3 versus 29.1. It's statistically significant. So the overall survival is not, this is what I was looking for, is not yet, it's an early trial, but I expect this to actually divide. So it's still too early for us to tell if there's an overall survival benefit. And then as far as the adverse effect, it's tolerable. Of course, we expect the diarrhea and what have you, but it's really very tolerable. So what is the implication to practice? The addition of palbociclib to anti-HER2 therapy may represent the new standard of care in this group of patients. So Happy New Year to everybody. And I am expectant that all this huge shift is going to be moving into the neoadjuvant and adjuvant world field. And if there's anything, I'm hoping that there will be a day whereby even if I can trade off chemotherapy in the group of, especially patients that don't need it, for less toxicity and side effect. Thank you very much for listening.
Abiola, for the HER2 positive, ER positive metastatic patients with first line treatment, you have palbo now as an option. If hypothetically tucatinib also becomes available based on the HER2 CLIMB-05 study, how do you pick between palbo and tucatinib in combination with trastuzumab and pertuzumab?
So I don't know that. I really don't know that question. I mean, so I think at the end of the day, it's more of a choice thing, right? It's more of a choice. In this group of patients, if I can do abemaciclib and Fesgo, I will do that. What would you prefer tucatinib to Fesgo?
I don't know, because we still worry about brain mets, and we don't have a strong signal with CDK4/6 inhibitors with brain metastases. It's effective in the sense that it gets across the blood-brain barrier, but it's not retained inside the CNS. So I'm just curious. It'll be interesting to see what HER2 CLIMB-05 looks like when it comes out.
Right.
So, any other questions from the audience? So there was a question online, whether would you choose from the Lumina strand and Elasta strand? What if you had both available? Which one would you choose?
So the disclaimer would be I chair MBAF. I'm on the on the diversity chair for MBAF. I'm not sure I want to answer that question. So it's more of side effects profile for me, and I haven't started using it in my clinic yet, but it's not, yeah. But when you start, it's like the palbo abemaciclib story. Initially, I was palbo. I've never used, maybe right, bro, maybe once or twice. I was palbo all the way. And then I started using abemaciclib. Then I was like, oh, I don't have to check for neutrophils anymore. Yeah, so I changed, right? So it's more of a practice then. And plus, most of my patients are like, well, that's fine. I want to be on abemaciclib. Then you don't have to do those weight loss tea because I have my weight loss drug. It's just, so it's more of a preference thing and easy, and then healthcare system thing, right?
Anybody else? All right. Well, thank you, everybody. Thank you, Abiola, for such a great talk. And yeah, hope to see you, everybody, next Wednesday. We have the last session. And oh, yeah.
Hold on, I've got some closing slides. Thank you, Abiola. Okay, hey guys, just quick end of session update. Okay. Can I just, okay. Okay, so if you signed in, you have not received this yet. I was actually in the back of the room getting ready to send it. So I am sending the email that will give you the link to take the post-test, the evaluation, and claim credit. This particular claim credit is for the continuing medical education credit. The instructions for how to claim IBIM and IBM MOC credit will be sent by Global Education Group. It will be sent to the email that you used when you signed in. So once I am done with these announcements, I will finish the email and you will have the CME instructions. Not happening now is our networking social hour right upstairs. So those of you remaining, please join us for some beer, some wine for a little less than an hour, just to kind of get out of the conference mode and to conclude the session with a little bit of fun. And then our next series session is next Wednesday. The topic is emerging paradigms in the management of oncology patients. Our session chair is Amin Salahuddin of that session. VK is a presenter of that session amongst some other faculty. So please, if you're available, come join us. We're also offering it online via an online broadcast if you can't come in person. But we would rather you be here than online, of course, if you can. And then also, these are our summer series dates. We have not assigned topics as of yet. We are thinking that the 11th may be hematology, and then between the 18th and the 25th will be solid tumors, and the other one would be women/GU. So we just have to finalize what we're going to slot in for those 3 dates. We have scheduled them conveniently in between ASCO and the first week of July, avoiding 4th of July. So it's those mid-June dates. And it will be at M-Hub, which is like right around the corner from here if you've never heard of it. And by the way, the parking is much easier. It's actually a building with a parking lot. And you don't have to pay for it. So anyway, thank you guys for attending today. And if you have any questions, email me. I am at the info@mymededco.com or Nicole@mymededco.com. And have a great time upstairs.